وكيل الوزارة للخدمات العلاجية، وتحت إشراف سعادة مدير الإدارة العامة لشؤون المراكز المتخصصة الدكتور عبد الله بن محمد السهيمي. نرحب بكم مرة أخرى، ونتمنى أن يكون هذا المؤتمر الأول للسعودي للأمراض الكلى له دور كبير في تحسين جودة الخدمة من خلال ورش العمل التي تقام على هامش هذا المؤتمر. والآن مع كلمة مع سعادة رئيس اللجنة العلمية الدكتور ياسين الحمد.
بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف الأنبياء والمرسلين نبينا محمد وعلى آله وصحبه أجمعين. السلام عليكم ورحمة الله وبركاته. يسرني أن أرحب بجميع الحضور الكرام في هذا اليوم المبارك الذي نفتتح فيه أولى أيام المؤتمر السعودي لأمراض الكلى، والذي سيكون برعاية وكيل وزارة الصحة للخدمات العلاجية الدكتور طريف الأعمى، وسيقوم بافتتاح المؤتمر الوكيل المساعد لخدمات المستشفيات الدكتور فيصل الدهمشي. وفي بداية لقائنا هذا أود أن أحيي جميع القائمين على المؤتمر، وبالأخص رئيس المؤتمر الدكتور عبد الله السهيمي، المدير العام للإدارة العامة لشؤون المراكز المتخصصة في وزارة الصحة، والزملاء في اللجنة العلمية واللجنة التنظيمية، وجميع المتحدثين ورؤساء الجلسات، وجميع الإخوة والأخوات الحضور. والشكر موصول لجميع الداعمين من الرعاة والمشاركين في التحضير لهذا المؤتمر، والذي استغرق ما يقارب 6 أشهر، وحصل على اعتماد 21 ساعة تعليم طبي مستمر من الهيئة السعودية للتخصصات الصحية. خلال ال3 أيام القادمة إن شاء الله التي سيستمر فيها أعمال المؤتمر، سيتم تقديم ومناقشة أكثر من 50 محاضرة علمية بمشاركة 23 متحدث دولي و25 متحدث محلي، وجميعهم من القامات العلمية المعروفة في مجالات أمراض الكلى للكبار وأمراض الكلى للصغار وتمريض الكلى وخبراء تقديم الرعاية الصحية. ستكون المحاضرات موزعة في القاعتين الرئيسيتين، وتقدم المحاضرات فيها بشكل متزامن حسب الجدول الموجود في موقع المؤتمر. ويمكنكم زيارة المعرض المصاحب للمؤتمر خلال فترات الراحة بين المحاضرات العلمية. أتمنى النجاح والتوفيق للجميع في هذا المؤتمر، وتحقيق الهدف الأسمى من إقامة هذا المؤتمر، وهو نشر المعرفة وتقديم المستجدات في الرعاية الصحية المقدمة لمرضى الكلى ومرضى الغسيل الكلوي، ومناقشة ما يتعلق في التحول الصحي في هذا المجال. أكرر شكري لجميع الحضور الكرام، وعلى بركة الله نبدأ النشاط العلمي لهذا المؤتمر. أدعو الأخوة الشير بيرسون لتقديم المحاضرين.
السلام عليكم ورحمة الله وبركاته. شكرا للزملاء في المراكز المتخصصة في وزارة الصحة على هذه الدعوة. يسرني أن أقدم أول متحدث، الدكتور بروفيسور عبد الكريم السويدة. بروفيسور عبد الكريم هو استشاري في جامعة الملك سعود في المدينة الطبية. He's known internationally and in Saudi Arabia for being a proponent and a specialist in glomerulonephritis, specifically in lupus nephritis, where he has several publications. So without further ado, I'll present Dr. Abdul Kareem.
Assalamu alaikum wa rahmatullahi wa barakatuh. I would like to thank the organizing committee for giving me this opportunity to present to you today. One of the important topics that commonly nephrologists see in their practices. So we are going to look into how we approach refractory lupus nephritis. So we will start with introduction, then we will go into the latest guidelines in the management of lupus nephritis, new therapeutic options that has been approved recently, and how to use cellular-based therapies, and suggested approach into how to manage cases with refractory lupus nephritis. So kidney involvement is really one of the common manifestation and presentation of patients with SLE. Eventually, 30 to 60% of these patients, they will develop lupus nephritis within the first 2 years of diagnosis. And these, once they have been diagnosed with lupus nephritis, this has a major impact on their mortality and morbidity. It needed to be captured early and managed very carefully to be able to prevent the progression to end-stage renal disease. 5 to 20% of these patients, eventually, they will progress to end-stage renal disease. This is a study that has been looked into the prevalence of end-stage renal disease among patients with lupus. And among them is the one that published from Saudis by Dr. Al-Arfaj. And it has been reported that 12% of patients with lupus, eventually they will develop end-stage renal disease. And as we said earlier, it's not going back, yeah. As we said earlier, the impact of lupus nephritis on the mortality is quite significant. I don't know why it keeps moving to, okay. And with 13 risk of death from cardiovascular diseases, if you compare them to the age match. Once they were diagnosed with lupus nephritis, many of them, they have cardiovascular diseases, and many of them also develop treatment-related complications, which include infection, ovarian failure, and fertility issues, and osteoporosis. The response of lupus nephritis to current therapy is suboptimal. This is what has been done in ALMS trial, which is very well controlled, and the patient has been seen, followed, and regularly, and you can see that the maximum that you will be able to get in terms of remission is 50 to 60%, so still at least 40 to 50% of our patients did not get the optimal response, and this is almost similar in different races. We have been convincing ourselves with a complete or partial responses, but we know that the outcome of partial responses is even not the optimal responses, and as we can see that, even those with partial responses within 10 years, at least 20 to 30% of them, they will develop end-stage renal disease. Those with no remission, majority of them, they will develop end-stage renal disease within 10 years. We know with every time that the patient develops a relapse, he will lose part of the nephrons that we will not be able to recover. And this is why quite critical to, in addition to early control of the diseases, is to try our best to prevent or decrease the number of relapses, because with every relapse, we will be losing part of the kidney function. So only immediate and very rapid control of intrarenal inflammation will be helping our patient with lupus to prevent the loss of their kidney function and to prolong the lifespan of their kidneys. If we look into the definition of refractory lupus nephritis, it's largely undefined. We are using inconsistent definition in the literatures, and this is making it quite tough to be able to reach into a clear conclusion into how to approach these cases and how to manage them. We know that it's not clear to us how to assess different parameters that we are using in terms of looking into the responses of patients. We heavily rely on proteinuria, and as we are going to see later on, even proteinuria, we just lately were able to come into conclusion what will be the optimal response of these patients. Many of these patients, even if you look to the proteinuria, they take them time to respond. It takes 1 to 2 years to reach into an optimal responses. However, sometimes we don't have the privilege of waiting for 1 to 2 years in these patients. The clinical responses, the one that we see in our clinics in terms of proteinuria or creatinine, does not correlate the immunological responses. And we know also that even reaching into clinical response does not necessarily mean that the patient does not have persistent lupus nephritis in their kidneys. In the latest guidelines by EU LAR and EDTA in 2019, they have came up with more clear guidance to the clinician what they are anticipating. So in 3 months, you should anticipate 25% reduction in proteinuria with a stable GFR. And by 6 months, you anticipate at least 50% reduction in proteinuria, and in 12 months, proteinuria to be between 0.5 to 0.7 in 24-hour urine collection, or protein to creatinine ratio. The KDIGO guidelines almost use the same thing. However, the amount of proteinuria is 0.5 grams per gram. So at least we know that we are using the proteinuria and the creatinine. And as you have noticed that, whether you looked into rheumatology or nephrologic literatures, the urine microscopies and hematuria or your white blood cells in the urine, they are not anymore considered part of criteria to define responses or remission. The drop of proteinuria in early phases also means a lot to the patients. As you can see, that those who have good long-term outcomes, they start to have significant drop in their proteinuria even in 3 months, and they usually continue to have more and more lower proteinuria. So early responses in terms of drop of proteinuria in patients with lupus nephritis does predict the long-term outcomes of these patients. So what we are using at this stage to predict preserved kidney function is proteinuria less than 0.7 grams per gram at 1 year. And this is it has been shown that it predicts the long-term outcomes. And this has been confirmed in multiple cohorts from different regions, and it has shown that 0.7 grams per gram of proteinuria is a good amount, Is it automated from your side, the show? So 0.7 grams per day is a good predictors for renal outcomes. In addition to the histological remission and evidence of no activities in the when we do the kidney biopsies. If we look into the latest guidelines in terms of the induction therapy and we compare them together, so we can notice that what has been endorsed by the KDIGO, in addition to the initial pulse steroid and the maintenance steroid, using the IV cyclophosphamide, the Eurolopus protocols, or using the MMF as initial phases. And the European guidelines, they have also added the multi-targeted therapy, which is using MMF 1 to 2 grams per day, in addition to the calcineurin inhibitors. We rely heavily on, in terms of looking to the biomarkers on the anti-DNA complements level, whether it's C3 and C4. And as you can see in the first table, the positive predictive value of these parameters that commonly being used is quite low. I mean, we are looking somewhere between 30 to, at best, 50% on most of these parameters that we use every day in terms of predicting the responses. So definitely we are lacking a good biomarker for the disease activities. This is one of the studies that we looked into, the repeated kidney biopsies in our cohort. And it has been noticed in 77% of patients. 1/3 of those who got partial remission, when you look to their kidneys, still they have active diseases. And even those who have no responses, 14% of them, when you do biopsies, they have no evidence of active diseases. So at this stage, we are using heavily the repeated kidney biopsy to assess the clinical responses. Still, we have a better biomarkers that will help us to assess the intrarenal inflammation and the systemic disease without the needing to go to a kidney biopsies. In the latest guidelines of the KDICO, the complete and partial responses has been well defined. And the treatment failure, or what we are calling refractory lupus nephritis, is failure to achieve partial or complete remission at 6 to 12 months of starting therapies. However, if you are noticing significant reduction in the patient kidney function at 3 months, or no response at all at 3 months, you should reassess this patient and you may consider switching their therapies to other than what you have started these patients on. One of the major issues that we come across in patients with lupus nephritis is non-adherence. We have looked into this again in our hospital, and 62% of patients with lupus, they admit non-adherence to their medications. You may have different ways to assess that. You can look into the hydroquinone level, hydroxychloroquine level in the blood, though in most of the hospital it's not available. However, what will be critical is routinely when you assess your patients, is you need to stress to them the importance of being adherent to their medications. And this is really will mislead many of us in terms of thinking whether we are dealing with refractory lupus nephritis or non-adherence. So when you assess a patient with refractory lupus nephritis, the first thing that you need to start with is verify adherence in different ways. And that's quite critical before labeling the patient that they have a refractory lupus nephritis, because switching them to other therapies will not help. Ensure adequate dosing of immunosuppression, because you can up-titrate whether you look to cyclophosphamide or mycophenolate mofetil to make sure that they have been receiving the adequate dose. And last but not the least is repeating the kidney biopsies. And repeating the kidney biopsies, we do it for multiple causes. If you are dealing with a flare of their diseases, or if they have partial responses, or stages of worsening of renal function. We usually, look into this if the patient is not responding after 6 months. In the early phases, probably doing them would not be helpful unless you are considering other differential diagnoses. And this is why also critical doing another kidney biopsies will help you to exclude other pathologies that standard therapy will not be helpful to them. You can capture antiphospholipid syndromes or drug toxicities if you use in calcineurin, or thrombotic microangiopathies, in addition to lupus podocytopathy or interstitial inflammation or lupus vasculitis, and all of these differential diagnoses that you may capture in the repeated kidney biopsies. The approach of therapy will be different than the standard care. We have been using the standard therapies, which is cyclophosphamide and MMF, though they have not been approved by FDA. And if you look, the last FDA-approved medication was in 1955. However, recently in December 2020, belimumab was approved for treatment of lupus nephritis. And the second medication that's been approved in 2021 was voclosporin. activation and the pathogenesis of lupus nephritis and lupus as a whole is not limited to activation of T cells or B cells. It's actually quite complex. You have T cells, B cells activation, and in addition to inflammatory markers. And when you want to approach these therapies, you have to look into targeting different mechanism of activation of the autoimmune diseases in our body. We will start looking into the T cell targeted therapies, the new medication, the voclosporin. We know this is similar to cyclosporin with a carbon extension. And this carbon extension have a major impact because with this carbon extension, you have a consistent dosing, so you don't need to monitor the drug level. And you have 4 times potencies than the cyclosporin A. The Aurora 1 and Aurora 2 looked into voclosporin as add-on therapies to the standard of care. So they randomize, one of the big randomized control trial in lupus, patients to either receiving MMF and steroid versus MMF, steroid, and voclosporin. And we have 2 phases because of the follow-up of these, Okay, so it went into 2 phases, phase 1 and phase 2, and it's comparing the standard therapy to standard therapy plus voclosporin. The inclusion criteria was patient with lupus with class 4 and 5, and class 3 and class 4 and class 5 was allowed to be also included in the study, with proteinuria more than 1.5 grams per day. And the primary outcomes was complete renal response at 52 weeks, defined as urine protein to creatinine ratio less than 0.5 with a stable renal function. And as we see in the outcomes of these studies, there is a significant response to those who received voclosporin in addition to the standard of care. 40% of them, they were able to reach into complete renal responses if you compare them to the control. One quite critical design in this study was the very rapid steroid withdrawal, because by 6 weeks, patients were on 5 milligrams, and this is quite quick tapering of the steroid, and this has a huge advantage. So the odds of achieving renal response in voclosporin therapy was 2.6 times greater than the control. We all get concerned about using the calcineurin inhibitors in terms of impairing the kidney functions. However, based on a long follow-up for 3 years, the estimated GFR and the serum creatinine seem to be stable and between, if you compare the standard of care and those on voclosporin. So we haven't seen any significant worsening of the kidney function with the use of voclosporin. If we move from T-cell targeted therapies to new medication for B-cell targeted therapies, the belimumab has been used extensively by rheumatology, and it has been approved since 2011. Sorry for this. However, it hasn't got into the nephrology literatures, and we don't have a randomized control trial till we have the recent publications for using phase 3 randomized control trial of using belimumab in comparison to the standard of care. So belimumab was given and compared to those who received the standard of care. The inclusion criteria was patient with lupus stage 3, 4, plus stage 5 with urine protein to creatinine ratio more than 1. And belimumab was given at baseline at 2 weeks, then 4 weeks, then monthly. And they compared the outcomes to the standard of care, which is using steroid plus MMF or cyclosporin and azathioprine. So those who received cyclosporin, they were continued in azathioprine and the rest of the standard of care. The primary endpoint was primary efficacy of renal responses, which is defined as urine protein to creatinine ratio less than 0.4, with a GFR more than 60 and stable renal function. And the secondary endpoint was complete renal responses, which is urine protein to creatinine ratio of less than 0.5, with a stable GFR and prednisone less than 10 milligrams per day after 24 weeks. If we look to the outcomes for primary endpoint, the primary efficacy renal responses was 55% greater odds of getting renal response in those who received benomimab. And if you look into the secondary endpoint, 74% greater odds of achieving complete renal responses in comparison to those who received the standard of care. However, if we look to the post hoc analysis, benomimab did not improve the outcome in those who received cyclophosphamide and azathioprine, and those with class 5. So these two groups, they did not show benefits from using benomimab. What has been noticed is a significant reduction in the renal flare-up in those who are in benomimab if you compare them to the standard of care, which is again something we have been not looking to in terms of the renal literatures, but we have mentioned earlier that preventing renal flare-up is quite critical to prevent worsening of kidney function. So there have been 55% reduced risk of lupus nephritis flare among those who received benomimab if you compare them to the standard of care. So when to use it? We use it in those who have renal impairment, patients with lupus nephritis flares, and those who their kidney function cannot sustain another flare because they may have a significant reduction in their kidney function. The second thing in terms of the B-cell targeted therapies is CD20 inhibitors. We know from the rituximab post hoc analysis that those who received rituximab and they were able to show significant drop in their CD20s, they showed a significant responses. And with that, in theory, hypnotizumab has been introduced and studied. It depletes faster rituximab's, it reduces the CD20s faster than rituximab's. By 2 weeks, 96% of patients, their CD19 count is less than 5 versus 52 in those with rituximab. So the nobility studies that have looked into adding hypnotizumab to the standard of care, and the inclusion criteria was almost similar to the other studies, which is class 3 and 4, and class 5 were allowed to be included with urine protein to creatinine ratio more than 1. And if you look into the complete renal responses, it was higher in those who receive hypnotizumab if you compare them to those who received the standard of care alone. And there has been shown that at least 20% difference, whether you look at 52 or even at 76 or 104 weeks after being randomized to hypnotizumab. The adverse effects were not significantly different between the two, except related to the infusion reaction, which can be easily controlled by pre-medicating these patients. So the hypnotizumab study showed that it was superior to the standard of care at 52 weeks when added to mycophenolate and steroid. And it showed improved renal responses in comparison to the standard of care at, even if you follow these patients at 2 years. Last but not the least, part of the new things that have been introduced into the management of lupus nephritis at early stages is using the cellular-based therapies, whether using autologous hematopoietic stem cells or using chimeric antigen receptors T-cell therapies. These are two new approaches. I know we have only small studies that looked into these. However, they are quite unique in terms of the approaches that we deal with patients with lupus. So in the hemobiotic stem cell transplantation, and this study was done in China, they treated 22 patients with hemobiotic stem cell therapies. However, the inclusion criteria was not strict, so many of these patients, they failed only one line of therapies and they were included. But despite of that, 18 out of 22 have complete remission. One patient did not have any responses. 2 patients, they died from the therapies, and 1 patient have a partial responses. 27% of these patients have relapses, and the overall responses was 95. So we know that this is not the optimal, but however, this is a different approaches how we handle patients with refractory lupus nephritis. The other promising approach is using chimeric antigen receptors, T-cell therapies. This has been used heavily in the oncologies, and basically you do the leukapheresis, you select the T cells, and you introduce to them a gene to make a CAR against a target, and in lupus we are targeting CD19. Then in the lab you expand this line of modified T cells and you reinfuse them again to the patient after conditioning chemotherapies, and you looked into the outcomes. This has been tested in 5 patients, and with a true refractory lupus nephritis. And really what was interesting in this studies is that they were able to induce remission with no therapies and all therapy and drug-free remissions in all the 5 patients. And I don't think we have ever been able to reach into that phase. So this is again one of quite promising approaches that hopefully in the future we'll be able to use more and more in patients with refractory lupus nephritis. I have how many? 2 minutes? Well, so most of 2 minutes, okay. So most of the data that we have is really from uncontrolled observational studies with different variable inclusion criteria and based on the small studies. But what has been suggested to how to approach these cases is starting with the standard of care, which is using MMF and Eurolupus trial. If patient is not responding at 6 months in terms of proteinuria, or if they have worsening of their kidney function at 3 months, then we should consider adding another lines of therapies. You can look at either adding to calcineurin inhibitors. You can use tacrolimus or voclosporin, though the issues of the cost with voclosporin is always an issue, or adding amnotizumab for these cases. The challenge is if the patient is not responding to this 3 lines of therapies of using multi-target with the CD20s, then really the evidence for what will be the next is very few, and we can look into the experimental therapies. We'll skip this. We know that in addition to controlling the inflammation, we need to look into non-immunological factors to prevent the worsening of the kidney function. So in addition to stressing of the adherence, we have to look also to how to manage the cardiorenal protective drugs, how to minimize the steroid and vaccinating these patients. So in conclusion, lupus nephritis is a common. Majority of these patients, they develop eventually lupus nephritis. Patients with lupus, they develop lupus nephritis. And once they have lupus nephritis, their morbidity and mortality is increased significantly. And when we approach these patients, we need to have a holistic approach to be able to assess the disease activities based on their clinical assessment, lab results, and other immunological parameters. Repeated or protocol biopsies is at least the available ways of assessing the patient responses if they don't have a significant responses in proteinuria, till we have a more accurate biomarker. Diagnosing and achieving complete or partial remission at 6 months is quite critical, because those who achieve partial or complete remission at 6 months, they have a good renal responses. A large number of our patients continue to have poor response. We have to develop how to reach into a more cost-efficient approaches, because many of these biological therapies are quite expensive. the most common cause of failure of therapy is non-adherence. And we have to monitor these patients closely, and if they don't show any responses and they are adherent to their medication, switching into other line of therapies. And we are quite optimistic that the new option of therapy will change the standard care that we are giving to all of our patients. Thank you so much.
Thank you, Dr. Prof. Abdelkarim, for this elegant talk. We'll leave the questions to the end of the first section, and we'll move on to the second lecture or talk.
So we'll welcome our next speaker, Vivid Kanjia from India. He's the Executive Director of the Georgian Institute for Global Health in India. He's also Prof and the Chair for Global Kidney Health, Imperial College London. He's well known for his prominent research in kidney. IgA is one of these scope of his research, and that's what he will talk about it today.
We have become used to doing this over Zoom now for the last 3 years or so, and I'm very happy to be with you at least via Zoom. Even though I'm not there with you in person in the room. So let me start by sharing my screen. Can you enable screen sharing for me, please? I'm getting a disabled screen sharing message, so if the tech team in the background will kindly allow screen sharing. Or share from your end, whatever is practical. I still am not able to share my screen, so I don't know if anyone can hear it, but as that is being sorted out, before I start, let me start by just reminding everyone that the topic of my presentation is evidence-based treatment of IgA nephropathy. We know that IgA nephropathy is the commonest glomerular nephritis worldwide, and that it has a very heterogeneous presentation, and the course is also not uniform. Some people progress faster, others progress very, very slowly or not at all, whereas a few will have waxing and waning course depending on the clinical presentation. We do know that a few factors are associated with faster progression. They include impaired glomerular filtration rate at presentation, presence of hypertension, especially if it is not controlled well. Obesity, if there is a factor. Those who present with and continue to have proteinuria, especially more than 1 gram a day, and of course, presence of hypercalcemia and hyperlipidemia are additional progression factors. We know that it's an immune-mediated disease, and therefore, in terms of treatment, the pathogenesis supports the use of immunosuppressive therapy. However, the overall risk and benefit balance of immunosuppressive therapy and various kinds of immunosuppressive therapy remains uncertain because the clinical trials have not given us definitive evidence. During the course of my presentation, I will review the current evidence and what is lies in the future for us. There have been tremendous advances in understanding the disease pathogenesis, which is helping development of targeted therapies. The current questions that we are having to deal with is when to intervene in a patient with IgA nephropathy.
Excuse me, Dr. Jia. Excuse me.
Yes.
Can you move your slides because we are just getting the first slide?
Just let us know.
Right. So I don't think I'm able to move my slide. It is sort of back end. So can the tech team please move the slide? Right. Thank you. So let me, because it's only in a window for me, I cannot see the active. So Right. So now the International Consortium of Researchers on IgA nephropathy have gone ahead and developed an international prediction tool for prediction of prognosis in IgA nephropathy. And you can see how this prediction tool was developed. So there was a derivation cohort shown on the left side of the figure on the left panel, and then there was a validation cohort shown on the right. And it showed that there were two models. There was one full model which used a number of parameters, but then a limited model which used only EGFR, mean arterial pressure, proteinuria at the time of kidney biopsy, and the MES score. You can see that both the full model and the limited model, they were very, very good predicting the 5-year risk of development of kidney failure. As you can see that all the various points on this graph are very, very close to the diagram which indicates the mean. Next slide, please. Now, using that information, an online calculator has been developed which you can, the URL is shown at the bottom, and you can go and easily enter the values for the risk prediction score, and you will be able to get risk prediction of what is going to happen to 5 years. Next slide, please. And you will get an individualized risk of a 50% reduction in EGFR or end-stage kidney failure up to 5 years following kidney biopsy. Next slide. We continue to look for new biomarkers, but the search for biomarkers has so far proven to be elusive. And without going into the details, let me just point out to you that the various biomarkers that have been currently investigated, including NGAL, KIM1, calprotectin, TIM2 IGF binding protein 7 multiple, etc., they have not been very good in predicting either full clinical remission or development of worsening of kidney function to EGFR less than 15. Next slide. Now, coming back to the pathogenesis, we know that the IgA nephropathy starts by abnormality in the IgA1 monomer. On the left, you see the normal IgA1 monomer molecule, and you can note that indicated in the blue and the brown dots are the various glycan moieties, which are either O-linked and N-linked. And you can see that these are able to combine with GalNAc and galactose and sialic acid. And the abnormality in IgA nephropathy is when the IgA molecule that is developed is underglycosylated. Next slide, please. But now, as I said, we understand the pathogenesis of IgA nephropathy a little more, and we understand that IgA nephropathy is a 4-hit process. The first hit is the production of increased level of galactose deficient IgA1, and then because of autoimmunity, our immune systems can develop IgG or immunoglobulin against this galactose deficient IgA1 because it is perceived as a foreign molecule. And this leads to formation of immune complex. And these immune complexes then start to circulate in the circulation, which is a 3rd hit. The 4th hit is when these immune complexes come and get deposited into the kidney and lead to mesangial proliferation and inflammation. Once that happens, there is activation of complement and further downstream cascade of events that lead to tissue injury and abnormalities in the kidney structure and function. Next slide, please. Now, just to complete the list, we know that there are a couple of other changes also that are seen in IgA nephropathy, one of which is podocytopathy. And those who have podocytopathy will exhibit high levels of urine protein excretion and behave like minimal change disease. The other abnormality, which we see less frequently, is microangiopathy, and these people will develop microthrombi. Next slide, please. Then moving on to the treatment of IgA nephropathy, what we know right now is, can we move to the next slide? That primary focus of management currently, based on current knowledge, is optimized supportive care. And we will talk a little bit about what this optimized supportive care is. We also should assess cardiovascular risk and commence appropriate cardiovascular protective interventions as necessary. All patients should be given lifestyle advice, which includes information on dietary sodium restriction, smoking cessation, weight control, and exercise as appropriate. other than dietary sodium restriction, there are no specific dietary interventions that have been shown to alter the outcomes in IgA nephropathy, including the use of fish oils and so on. As I said, there are a few variant forms of IgA nephropathy, which is minimal change disease or podocytopathy. And IgA nephropathy can be associated with acute kidney injury, and when that develops, and we need to do a kidney biopsy, and sometimes patients may show crescentic glomerulonephritis, and that crescentic glomerulonephritis may require specific immediate treatment. Next slide, please. Now, but there are a whole host of things that we do not know yet. For example, there is currently insufficient evidence to support the routine use of the MESC score in determining whether or not we should treat a patient with immunosuppression. We also don't know what does the number of crescents mean in terms of developing treatment decisions. And finally, even though the IgA nephropathy risk prediction tool is useful in predicting risk, it is not helpful in identifying what will happen as a result of any specific treatment that we give to these patients. Next slide. Now, coming back to a few points of detail in treatment of IgA nephropathy, dietary modification is critical, but the only dietary modification, as I said a little while ago, is that we can advise on an evidence-based manner is salt restriction, because it has been shown to reduce proteinuria even in normotensive IgA nephropathy subjects. Low protein diet has no evidence for supporting progression or prevention of progression of IgA nephropathy. Weight optimization is important because a relationship between weight and likelihood of proteinuria remission and end-stage kidney disease development has been shown in observational studies, whereas there is randomized clinical trial evidence that weight loss may be beneficial in those patients with IgA nephropathy who are overweight. Smoking cessation, both cohort studies and case control studies have shown that independent and dose-dependent risk factor for progressive kidney function decline in IgA nephropathy is smoking, and thereby all patients should be advised to stop smoking if they are smoking at that time. Renin-angiotensin system blockade remains the first-line management in IgA nephropathy, and several randomized clinical trials and meta-analysis have shown its beneficial effect, which was corroborated most famously in the Stop IgA Nephropathy trial. But the dual blockade with angiotensin converting enzyme inhibitors and angiotensinogen receptor blockers remains controversial. Tonsillectomy is very widely practiced in Japan. It is postulated to work by reducing upper airway infections and production of poorly O-glycosylated IgA1 from the tonsillar lymphatic tissue. There are a number of uncontrolled retrospective studies from Japan that have shown reduction in proteinuria following tonsillectomy, but the same studies, when repeated in Europe, have not shown any benefit. Next slide, please. Now, in recent years, we have seen expansion of this non-specific immune suppressive. Next slide. The non-specific immunosuppressive therapy by addition of SGLT2 inhibitors. And the strongest evidence came from the DAPA-CKD trial, which demonstrated the effects of dapagliflozin on reduction in major adverse kidney events in patients with IgA nephropathy. So the DAPA-CKD population included 270 participants with IgA nephropathy, out of which 254 had biopsy-confirmed IgA nephropathy. And you can see that the hazard ratio for the composite primary endpoint in patients with IgA nephropathy was reduced by as much as 71% in those treated with dapagliflozin. So now there is a very, very strong movement around the world and suggestion that SGLT2 inhibitors should be added to conservative care in addition to RAS blockers in patients with IgA nephropathy. Next slide, please. Now, there is a likelihood that this armamentarium of non-specific therapy might get expanded by inclusion of endothelin receptor antagonists. And the evidence has started to emerge in that. And the first one is from this phase 2 trial on atrasentan in patients with proteineurogranular diseases. So this was a basket study in which atrasentan was tested in patients with a variety of primary glomerular diseases, IgA nephropathy, FSGS, Alport syndrome, and diabetic kidney disease. And in 20 patients with IgA nephropathy who were treated with atrasentan for 52 weeks and followed up for four more weeks, Next slide, please. The study showed that atrasentan provided clinically meaningful proteinuria reduction in patients with IgA nephropathy who were already on the background of optimized supportive care. So within about 6 weeks, there was a 38% reduction in proteinuria. And by the time 24 weeks came along, the proteinuria reduction had increased to 54 weeks. Next slide, please. So based on these findings, atrasentan has moved into phase 3 clinical trial. And this is the schema of this phase 3 clinical trial, that the patients will be screened and will receive optimized supportive care. And then they are being randomized to receive atrasentan or matched placebo. And the treatment will happen for 132 weeks. And then the patients will be followed up. And currently, this trial is enrolling patients from around the world. Next slide, please. Now, moving on from the supportive therapy, let's see where we are with regard to use of immunosuppression. Next slide. Now, the first thing that we think of when thinking of immunosuppression in IgA nephropathy is the use of steroids. So steroids have been used in treatment of IgA nephropathy for more than 25 years. And the first evidence was presented in 1997 by the Gissen group, which showed that ramipril decreased proteinuria and rate of eGFR decline in non-diabetic patients overall. In 1999, Dr. Pothy and colleagues showed that steroid group had better outcomes compared to those who were treated just with blood pressure control and diuretics. At that time, they did not receive ACE inhibitors because that had not become standard of care. Moving on to 2007, Mano et al. Compared ACE inhibitors versus ACE inhibitors plus placebo. And these patients were followed up for 8 years, and steroid group had better outcomes. In about 2012, Ji-Cheng Lu and colleagues conducted a meta-analysis which showed that steroids were potentially associated with a lower risk of kidney failure and decreased proteinuria, but were associated with a significantly increased risk of adverse events. And that led to the institution of testing trial. But alongside testing trial, the Stop IgA Nephropathy trial also had started, and it published its results in 2015, where immunosuppression did not improve outcomes and in fact was associated with more adverse events. The testing high-dose trial were reported in 2017, and in testing high-dose trial, steroids had to be stopped early due to safety concerns in the steroid group compared to those who were receiving RAS blockade only. Next slide. Following that, the testing trial was modified and the steroid dose was reduced. And the question that the testing trial overall asked was, what were the effect of oral glucocorticoids compared with placebo in those with IgA nephropathy and proteinuria of 1 gram per day, which means at higher risk of progressive kidney disease after they had been treated with optimal supportive therapy. So in this trial, a total of 305 men and 198 women were finally included, and they were treated with methylprednisolone, as you can see, 6 to 9 month course of oral methylprednisolone versus matching placebo. And the primary outcome was a composite outcome of first occurrence of a sustained 40% decline in eGFR, kidney failure, or death due to kidney disease. And this trial was done in 67 medical centers worldwide. Most of the centers are located in China and India. The findings showed that the primary outcome occurred significantly less frequently in the methylprednisolone group. So you can see 28.8% of patients in methylprednisolone group reached primary outcome, whereas it was 43.1% in the placebo-treated group, leading to a hazard ratio of 0.53, which means that there was a 47% reduction in the risk of development of the composite adverse events. And this is the same thing shown in somewhat different format. Next slide, please. Next slide. I want to make the point using this slide that just concentrate on the right-hand side here, that the serious adverse events were seen much less frequently in the group of subjects who received reduced dose of steroids. So the number of serious adverse events was 22 in full dose steroid cohort, 6 in the reduced dose steroid cohort, whereas it was 7 in the placebo cohort, which means that the reduced dose steroids was no worse than placebo in terms of serious adverse events. Next slide, please. Which means that testing trial showed that there was possibly benefit in treating these patients with steroids, which was used in the low-dose protocol. Now, if we simply compare the three trials that we just spoke about, the STOP IgA nephropathy trial, the testing trial, and DAPA-CKD, you can see that the number of subjects in the STOP IgA nephropathy, all the subjects were Caucasian, whereas in testing trial, 96% of the participants were recruited from Asia, and the split was more even in the DAPA-CKD, but still Asia predominant. And you can see the age. Patients enrolled in the DAPA-CKD trial were a little older. The amount of proteinuria was greater in testing trial compared to STOP IgA nephropathy and lowest in the DAPA-CKD study. EGFR was lower in the DAPA-CKD study at the time of enrollment. You can see the EGFR loss was, even in control arm, was much, much less in the STOP IgA nephropathy study, which might have indicated that these were relatively low-risk subjects, and you can see the histology at the bottom. Next slide, please. Now, let's shift gears to see what is there ahead of us in the future. So, as I said, we are understanding the pathogenesis of IgA nephropathy a little better, or rather quite a lot better, and therefore new therapeutics are being developed which are targeting specific pathogenic mechanisms. And they're starting from, on the bottom left, you can see bortezomib, which targets proteasome, which will hopefully reduce the development of antibodies, to budesonide, and we will see a little bit more about it, which targets the mucosal lymphoid tissue, to a number of strategies which are targeting the gut flora, including gluten diet, antibiotics, and probiotics, and then targeting of specific mediators, using, for example, abatacept, which targets BAF, and anti-APRIL molecules, and then IgA1 protease is being developed, and finally, a lot of emphasis is being placed on complement inhibition to reduce tissue injury. Now, the first thing is the budesonide, which targets Peyer's patches in the gut-associated lymphoid tissue. And the drug which is now available is called now Nefecon. These are enteric-coated starch capsules filled with budesonide-coated spheres. And the result of NefIgArd trial, which was a randomized placebo-controlled trial of evaluation of targeted release budesonide, was published just last month in Kidney International. It enrolled 199 patients with IgA nephropathy with UA protein creatine ratio of more than 0.8 and EGFR between 35 and 90. They were treated for 9 months and then observed for an additional 3 months. The primary endpoint was urine protein creatine ratio after 9 months. And as you can see, that patients who were treated with budesonide showed a significant reduction in urine protein creatine ratio, both in the treatment phase and in the follow-up phase. So you can see the slide at the bottom, which is slanting downwards, is Nefecon 16 milligrams. And you can see on top, the one with open diamonds is placebo-treated subjects. And then when they looked at the change in EGFR, the budesonide-treated subjects exhibited a relative stabilization of EGFR, whereas those treated in the placebo arm had continued a decline in EGFR. Next slide, please. Next slide. So this is the trial that I was talking about, which is the NefIgArd trial. Next slide. And this, you can see the reduction in proteinuria. And next slide. This shows the stabilization of EGFR. Next slide, please. Now, coming to the KDIGO recommendations, which were published earlier this year for treatment or management of patients who are at high risk of progression of of disease despite supportive therapy. Next slide, please. As you can see in the box in the middle, the KDIGO guidelines currently recommend that we enroll all of these subjects in a clinical trial. And next slide. We know that a large number of clinical trials are currently ongoing, and the molecule that is receiving the highest attention is APRIL, which is or the proliferation-inducing ligand. This is a molecule of TNF superfamily cytokine, and it is involved in B-cell signaling. APRIL drives IgA class switching and survival of IgA secreting plasma cells through TACI and BCMA. And there is some genetic and clinical evidence that April is associated with IgA nephropathy. Higher April levels in IgA nephropathy patients correlate with the higher galactose deficient IgA1 and proteinuria and lower EGFR. And there are certain gene variants which confer increased risk of IgA nephropathy. And these gene variants have been shown to increase galactose deficient IgA nephropathy, increased secretion from lymphocytes of these IgA nephropathy patients. Next slide, please. So there are a couple of molecules which are targeting APRIL, one of which is sibeprenlimab. It blocks APRIL and prevents binding to TACI and BCMA and leading to neutralization of APRIL. And the figure on the right shows the structure of sibeprenlimab. Next slide, please. And the phase 2 trial, which was just completed, and the results of that trial were presented at ASN. Next slide. Shows the design of this study. Next slide, please. Yes. So this phase 2 study evaluated the effect of different doses of sibeprenlimab, randomized in 1:1 ratio into 4 groups, and the fourth group was, of course, placebo. These patients were treated with monthly injections for 12 months and then followed up for 4 more months. Next slide, please. And you can see that the use of this agent was associated with a significant decline in urine protein creatinine ratio. You can see baseline to the sibeprenlimab compared in the 2 groups was as high as 40%. And next slide. And once again, you can see that there is a stabilization of EGFR in those who were treated with sibeprenlimab compared to those who were treated with placebo. Next slide. The next molecule that is targeting APRIL is the BION 1301 molecule, which is a humanized anti-APRIL monoclonal antibody, which again binds both human and cynomolgus APRIL, but does not bind rodent APRIL, and it blocks functionally. Can you hear me?
Yes, doctor, we're hearing you. You can proceed.
Next slide, please. Can we go to the next? Yes. So now BION in phase 2 trial, the BION molecule also showed a significant reduction in proteinuria with the use of this agent. Next slide. And this one has also now entered a phase 3 trial. And you can see the phase 3 study schema here. And hopefully we will have more than one option for successful treatment of our patients with IgA nephropathy. Next slide, please. Next slide. And this is now moving on to complement. So this is a new anti-complement compound from Novartis, which again was tested in phase 2 trial and showed a significant reduction in proteinuria. And next slide. And as a result of that, this one has also moved to a phase 3 trial called Applause. And in this phase 3 trial also, patients are being randomized to receive this anti-complement molecule and placebo. And we will see potentially whether this one, the results are borne out in phase 3 trial as well. Next slide. And yes, and this is the last one that I'm going to show, which is you can see the phase 2 trial results. We show a significant reduction in proteinuria of another anti-complement compound, and this one has also entered phase 3 trials. Next slide. So therefore, I come back to my point from the KDIGO recommendation about management of patients who are at high risk of progression despite supportive therapy. Next slide, please. And just making the point that we are obliged to recruit our subjects into one of these many global randomized clinical trials that are currently underway to get the best evidence for treatment of our patients with IgA nephropathy. It is fantastic that there are so many options are being considered, because our patients will have the option to choose from one or more, and even if one therapy fails in one patient, potentially another pathway, targeting another pathway will be possible to improve the outcome of that particular individual. Next slide, please. Therefore, and this is the list of trials that are currently underway. Next slide. So I didn't talk about a number of things in IgA nephropathy, such as IgA vasculitis or treatment of IgA nephropathy in children. But here you have the summary of what do we know about the treatment of IgA nephropathy in our patients. That there is a lot of excitement in our improved understanding of the pathogenesis of IgA nephropathy. This improved understanding of pathogenesis of IgA nephropathy is leading to development of exciting new targeted therapies, and a lot of clinical trials are underway by both academics and pharma industry. So this is a golden era for patients with IgA nephropathy, and hopefully in the next 2 to 3 years, when all of these trials complete recruitment and publish the results, we'll have possibly a plethora of therapies for patients with IgA nephropathy. But we have to remember that these are almost all of these are biological molecules. They are likely to be expensive and will potentially be out of reach for many patients who live in low and lower middle income countries. And it is our responsibility to make sure that the benefit of new medical knowledge becomes available to everyone around the world, no matter in which country they live or whatever is the socioeconomic status. I'm going to stop here and thank you all for your attention.
Thanks, Dr. Gia, for this very informative and focused presentation. Since you are through Zoom, so we are afraid that we might lose connections with you, so we'll open the floor for a few questions. If anyone interested to ask any questions.
Thank you so much, Prof, for this excellent and elaborations for the incoming trials, which will change the guidelines of IgA. I know in the coming, months. So my question about the, I know IgA, it's the most hyperdynamic GN, subtype. So the SGL2 now and DABA CKD and IMBA kidney, it showed a very excellent effective in IgA perspective and compared to the other GN. So what do you think the future of the SGL2? Because now it is in the market and now it is leading the CKD, management.
Thank you for your excellent question. You are exactly right that the SGLT2 inhibitor has shown a lot of promise, and there is interest in the global nephrology community to add SGLT2 inhibitors to the standard of care for patients with IgA nephropathy who continue to remain proteinuria despite ACE inhibitor therapy. In fact, most of these new phase 3 clinical trials now are allowing patients to receive SGLT2 inhibitors in addition to ACE inhibitors and angiotensin receptor blockers before they are getting randomized into one of these new targeted therapies. So I would suggest that yes, SGLT2 inhibitors are going to be used quite widely, and it would be very difficult to prevent their use, given the fact that they have an excellent safety profile as well. So there is very little argument against adding SGLT2 inhibitors to standard of care in patients who continue to have proteinuria despite ACE inhibitor therapy. Thank you for that question.
Thanks. So because we're running out of time, so we apologize. We'll not accept any more questions. Thank you, Dr. Gia. We hope to see you again.
Thank you very much.
We'll move to the next speaker.
So it's my pleasure to present our next speaker. He is Professor Giuseppe Ramuzzi. He is actually the Professor of Nephrology, Director of the Department of Immunology and Clinical Transplantation at the University of Bergamo, Italy. He is a recipient of several awards from the ISN, the ASN, and I'm sure he's well known to everyone in this hall. So without further ado, Professor Rimozzi.
Hello, could you hear me?
Yes, we can hear you, Professor.
Okay. Thank you very much for the invitation. Could you see my slide? May I have my first slide?
So if we can upload the slides. So it's just waiting for the technical team to upload the slides.
Okay. I have to do it. Cosa?
Intervallo.
So, Professor Rimozzi, can you see the slides?
Non è questa. Seconda questa. Devi dirla loro, ci viene.
Okay. May I have the next slide?
So I think this is the slides for the second tongue. Hold on a second. Right now we have the,
Okay.
because Professor Rimozzi is presenting two lectures.
Yeah.
So this
This is the complement one.
This is the complement. There's another lecture for the membranous.
Yeah. Yeah.
And I apologize.
You would
for
like me to
everyone.
start with complement?
No, we'll switch to the other, to the previous slides.
Okay.
The membranous, please.
Okay. Okay. You can see this nice histology on membranous nephropathy. Next one. Next one. Okay. Here is the prognosis of untreated patients. Many years ago, we have done an interesting study in which
100 consecutive patients have been followed for 8 years without any immunosuppressive therapies, simply supportive therapy. So lowering hypertension, treating nephrotic syndrome, and so on. And the importance of these slides is the first natural history of untreated patients with membranous nephropathy, showing that actually at least 75% of patients actually go into spontaneous remission, and they survive up to 8 years. Next one. Then we compare the probability of renal survival from a pooled analysis of 22 studies, including more than 1,000 patients that were given alkylating agents, steroids, and all of them, of course, were retrospective study. And we compare renal survival with the renal survival of our patients with no treatment, and you see that there is not too much difference. So this shows that our choice of not giving patients immunosuppressive drug was not so wrong at the end of the day, if you consider the side effect of this drug. May I have the next one? Here is the comparison between alkylating agents and placebo or no treatment. And you see that there is a marginal effect favoring alkylating agents, but both in complete partial remission or in end-stage renal failure and death. Actually, as for end-stage renal failure and death, there was no significance, despite the fact that numerically it seems to favor alkylating agents. So essentially no effect on end-stage renal failure and death, a marginal effect on, non-significant by the way, on complete and partial remission. But if you look carefully, the only significant was for this particular study. If you remove this study, there is no way of documenting that alkylating agents are any better than supportive therapy. Next slide. So there is also something more important to take into account, considering this particular study that showed a favorable effect for alkylating agents. And this was that the treatment benefit was confined to patients with serum creatinine level less than 1, that is, those patients who seldom progress to end-stage renal disease, even without immunosuppression. Next one. This is not terribly clear, at least to me, but is the UK randomized trial showing in patients with biopsy-proven membranous nephropathy and more than 3 gram serum creatinine and more than 20% eGFR as baseline, that prednisone and chlorambucil actually were better than supportive therapy and cyclosporine. Actually, cyclosporine was worse than supportive therapy. And those were patients with severe renal insufficiency. So this is the only acceptable evidence of a superiority of prednisone and chlorambucil to supportive therapy. However, look that there is a reduced number of patients, and the time of recruitment for this study, if I'm not wrong, was something like more than 12 years. So it's a study by which patients were, so a low number of patients were collected along a huge number of years. So in total, however, patients with chlorambucil, next slide, please. Had very serious adverse event. Including bone marrow suppression, impaired glucose tolerance, infection. Cyclosporins also had side effect, but patients on supportive therapy, the side effects were really trivial. So chlorambucil was probably better than supportive therapy, but at the expenses of very important side effects. Next slide. On the other hand, we know that cyclosporin therapy in patients given this drug for other conditions, like malignant, like Wegener granulomatosis, for instance, are associated with a number of malignancies, including acute myeloid leukemia, blood cancer, and non-melanoma skin cancer. And so if you think it's reasonable to give these particular drugs who have so much side effect in a severe acute disease like Wegener granulomatosis, I don't think it's justified in a disease that may have spontaneous remission in a large percentage of cases, like membranous nephropathy, particularly if you give this drug to patients that have a not severe proteinuria and almost normal renal function. So clinicians, next slide, and their patients will have to decide whether the benefit of prednisone plus chlorambucil justify the substantial risk of harm. Cyclosporin, however, should not be prescribed, in my view, because it offers no benefit compared to standard therapy and is associated with severe side effects. Next slide. B lymphocytes are the crucial cell in membranous nephropathy. They act as antibody producing, as you can see here. And also, as you can see here, as antigen presenting cells. Data from study in animals, mainly from Keriaski, suggests that the typical subepithelial immune deposits in glomeruli are caused by B-cell mediated reactions, which promote injury to the glomerular filter barrier, resulting in proteinuria. So, following this paper, we decided that agents which specifically interfere with B cells could be ideally considered the first step towards selective therapy of membranous nephropathy. Next slide. Actually, one of these drugs is rituximab. Rituximab is a humanized antibody against CD20 on the surface antigen on B cells. And you can see here the murine variable region of this monoclonal antibody that contains the CD20 binding site. Here you have the C1q binding sites, and those are in fact the human constant kappa region. Rituximab reduce rapid depletion of circulating B cells via antibody-dependent cytotoxicity, NK cell and complement activation, and also inhibition of B cell differentiation and IgG secretion upon CD20 binding by the antibody. Next slide. At the beginning, and I like you to realize that this first patient was recruited in 1999. This is a very important date to remember. Actually, in my view, is the only thing you have to remember from this talk. And I will show you why in a moment. We have selected few patients, 8 patients altogether, with biopsy-proven membranous nephropathy. However, as opposite to previous trial, those patients had a proteinuria more than 3 grams for 6 months, and no previous remissions. And also they had ACE therapy for more than 6 months. So we select severe patients that had the possibility to go into spontaneous remission, because before starting rituximab, we waited for 6 months on ACE inhibitor. Those 8 who did not went into spontaneous remission after 6 months of ACE inhibitor entered this small trial with rituximab for weekly IV infusion, 375 milligrams per square meter. And the primary efficacy variable was 24-hour urinary protein excretion. And you see a important reduction in proteinuria that actually was reduced by 50% in matter of literally few days. Then proteinuria stabilized. Proteinuria did not normalize in this particular trial, and I will show in a moment why. Next slide. If you compare the first biopsy with the second biopsy, you see that deposits were no longer detectable in 2 of the 7 repeated biopsies and were replaced by electron-lucent material in remaining 5 samples. And you see, in this particular patient, for instance, in the second biopsy, you literally can see slit diaphragm, which was completely lost in the biopsy before. So associated with reduction in proteinuria, we saw a important amelioration in the level of tissue injury in these patients. Next slide. B-cell driven rituximab. So rituximab given according to the reduction of CD20 B cell in 7 days versus the standard protocol that hematologists were used at that time, which was much more important, like 1 administration every week for 4 weeks. We found that B-cell driven rituximab, so you look at the B cells and see when these cells disappear, you stop giving rituximab, induce the same proteinuria reduction and B-cell depletion. Then here is proteinuria reduction and the same B-cell depletion. Then standard dose of rituximab that hematologists were used to use for B-cell lymphoma. And this was logical because in B-cell lymphoma, you have billions of cells around, while in membranous nephropathy, the pool is much more reduced. Also, whether a patient had previous immunosuppression or they were referred to us as the first refer without previous immunosuppression, show no differences. And the cost, of course, B-cell driven costs much less than standard therapy of rituximab, like the one that hematologists use for B-cell lymphoma. In fact, in standard protocol, we have also a number of severe reactions, while in B-cell driven protocol, we have essentially one mild reaction. Next slide. Here is the outcome of 37 patients given a standard course of rituximab, divided by those who had more than 3 gram proteinuria to start with, those who have between 0.5 and 3 gram proteinuria, and those who have less than 0.5 proteinuria to start with. And of course, you can see that residual proteinuria is dependent on proteinuria at the beginning of the observation. The red line had a less effective reduction in proteinuria at the end. But in fact, the difference as compared to the beginning is always significant and really substantial. Those who have lower proteinuria, I mean between 0.5 and 3 gram, normalize that proteinuria at the end of 36 months. However, please note that in order to see normalization of proteinuria, even in these patients, you need to wait at least 18 months. So you don't have to give rituximab to your patients and expect to see a proteinuria normalization in matter of weeks. You see reduction in matter of days and weeks, but certainly in order to see a proteinuria normalization, you need to wait a certain number of months. This was done, next slide, before we knew the target antigen in idiopathic membranous nephropathy. Actually, the long-lasting mystery has been solved by the discovery that autoantibodies against podocyte cell antigen circulate and bind to a conformational epitope on phospholipase A2 receptor expressed on podocytes that colocalize with IgG4. Actually, in 2004, it has been discovered by Salant and Beck that the target antigen was indeed this phospholipase A2 receptor, a transmembrane protein specifically bind to secreted phospholipase A2 enzymes. In humans, phospholipase A2 receptor is normally expressed in lung, placenta, and kidney by podocyte close to the GBM. Here in red, you see this epitope, CSR, that is extremely important, and as you will see in a moment. How many patients with membranous nephropathy have indeed an antibody against this podocyte antigen phospholipase A2 receptor? This is something around 70%. 30% of patients do not have circulating anti-phospholipase A2 antibody, and you will see that now we know they have other antibody associated with this disease. Next slide. Here we studied 100 patients with membranous nephropathy with persistent proteinuria, biopsy-proven idiopathic membranous nephropathy, proteinuria more than 3 grams for 6 months, no previous remission, and days therapy for 6 months. Again, these 100 patients were selected for having had ACE therapy for 6 months without spontaneous remission. So in this series, you have to reasonably exclude that patients who could have theoretically spontaneous remission were admitted to the study. And this is important because this is the only study in which patients that could have benefited spontaneous remission were excluded by protocol, starting after 6 months of ACE inhibitor with no remission. The endpoint were complete remission or partial remission, defined as you can see. Next slide. Here you see that among the 100 patients, 30% reach complete remission with rituximab, 1 dose, partial remission, another 30%. Together, patients with complete or partial remission reached more than 75%. And those with complete remission as compared to baseline also had an improving GFR, which is true GFR, not measured GFR, as opposite to those who had no remission, this small group of patients that have no remission, and actually they have a reduction in follow-up GFR as compared to baseline. Next slide. Here you see why in the first 8 patients given rituximab for a few months, we only observed a reduction in proteinuria in 50%. When we presented these 8 cases in the Lancet at the beginning, some people criticized this approach because they said, well, it only induces a partial reduction of proteinuria, 50%. The reason is that those people did not realize that in order to see a complete reduction in proteinuria, you have to wait in this disease. If you wait for 36 months, you see that now all these patients reach a reduction in proteinuria, and at 6 months, you see normalization of proteinuria. So it's a time-dependent phenomenon, and you see the cohort altogether reach a substantial reduction of proteinuria in a matter of 60 months. Next slide. Probability of spontaneous or partial remission according to detectable or undetectable antiphospholipase A2 receptor antibody at baseline. This is probability of remission, complete or partial, in those who has detectable antiphospholipase A antibody, which is very similar to those patients who had not detectable antiphospholipase A2 antibody. We don't know which kind of other antigens are involved in this particular group of patients, and I suspect that thrombospodin or NEL1 that are recently discovered antigen associated with membranous nephropathy probably account for the fact that despite we don't know the antigen involved and the corresponding antibody, rituximab is also effective in those that do not have detectable antiphospholipase A2 antibody. Next slide.
Professor Ramuzzi, we have 3 more minutes.
Okay. Probability of complete or partial remission according to the tertile of antiphospholipase antibody, you can see here. Highest is the tertile, higher is the probability of complete or partial remission. And you can use anti-cis title, and the anti-cis title is associated with remission is if is higher than partial remission if it's higher than the median, but important remission if is lower than the median. Next slide. here you see that severe side effect in this comparison that we have done between 100 patients in Bergamo and 100 patients in Netherlands. Those who are given rituximab, those who are given cyclosporine. All the severe side effects were associated with cyclosporine, none in the rituximab group. Next. Next slide. Again, you see the previous one were severe side effect. You see now the serious event, again, all on cyclosporine group, treated in Leiden, in Holland, none in the rituximab. This is not a trial, a controlled trial. Next. A formal trial was done recently using rituximab or cyclosporine in the treatment of membranous. Next one. At 44 follow-up, 39 of 66 patients, 60% in the rituximab group had complete or partial remission, as compared to 13 of 16 patients, 20% in the cyclosporine group. The author found a large difference between rituximab and cyclosporine regarding the percentage of patients in complete remission, 35 versus none. This observation is one of the most important findings of the trial. Unfortunately, this was in the supplementary material. Also, progressive loss of renal function was lower with rituximab. Next one. I think that this can be the actually this last slide. That is the comment we did on the trial of Pervenza and Tal. Grateful as the renal community should be to mentor investigators for providing their data, showing the superior effect of anti-CD20 approach with membranous nephropathy. Nearly 20 years have elapsed. This is 2019. You remember our first patient was 1999. 20 years have elapsed since the first demonstration that rituximab induced remission of nephrotic syndrome in such patients. At this point, one may wonder how many patients were exposed to side effects of alkylating agents over that time, and how many patients have died unnecessarily because of this treatment with alkylating agents. There is many other approaches that I wanted to tell you about obinutuzumab and ofatumumab in patients that do not respond. And also, we have now a trial with an antiplatelet, an anti-plasma cells drug, anti-CD38, in those patients that, for various reasons, do not respond to the rituximab therapy. But in the interest of time, I will stop here, telling you, please do not use these alkylating agents any longer in these patients, and consider rituximab or ofatumumab or the antiplatelet agents as the first approach to membranous nephropathy patients. Thank you very much.
Thank you very much, Professor Remuzzi. In the interest of time, we'll defer the questions to after the second talk. So there will be no break given the time constraint that we have, and we'll be starting with the second talk of complement disease. I'll allow the chair people to come and present.
Bismillah ar-Rahman ar-Rahim. Initially, I would like actually to thank the scientific committee and organizing committee to inviting me with my co-chair, Dr. Al-Araini, to chair these sessions, which is the plenary sessions. And we'll start with the same speakers, who's a well-known speaker, actually, Professor Ramosi, and he will talk about the C3G. So the mic is at yours, Professor Ramosi.
Yeah, may I have the next slide? Could you hear me?
Yes, there will be no break. We'll start the talk now, yes.
Okay, may I have the next slide? In this slide, John Atkinson showed that after so many time of study of complement, finally we have at least 2 drugs, and this is 2012. Next one. There are many diseases, including renal diseases associated with complement activation. We have an interest in hemolytic uremic syndrome, MPGN-C3 glomerulopathy, and now recently COVID-19, that is a complement-mediated disease, at least in part. I will address today hemolytic uremic syndrome and MPGN-C3 glomerulopathy. Next slide. You see the incidence, no sex difference. This disease is particularly frequent in Argentina. Next slide. Next slide. We have also a registry of patients with HUS-DTP. As you can see, there are samples and clinical information that are sent to us from all over the world. Next slide. This is a disease of alternative pathway of complement, and the 2 crucial enzymes that are formed in excessive amount, being responsible for the formation of C5b9, are C3 convertase and C5 convertase. Next slide. Next. This is a very important paper published in 1998. We found, of course, not we, but a good ship found in Newcastle 3 large family with HUS. In 3 large family with HUS, an area on chromosome 1q32 where factor H gene is mapped that's segregated with the disease. Here you see the factor H. Factor H is constituted by 12 short consensus repeat, all identical. You have a regulatory domain that binds to C3b and a recognition domain on the surface of endothelial cells that bind to C3b and proteoglycans. Those are different mutations that we and others have found and stopped counting the mutation in 2013, that were too many. We have found 80 different mutations in the 120 patients. 90% are heterozygous, most in the recognition domain. Next slide. A typical HUS is a solid phase restricted complement activation. Next slide. Next slide. actually you see that mutated factor H via regulatory domain still dissociate BB from C3b, allowing the activity of C5i and resulting in the formation of C3b inactivated material. But in solid phase, in solid phase, if you have a mutation in the recognition domain, like in this one, now you have a mutation in the recognition domain that cannot bind any longer to C3b and glycosaminoglycans. So next slide. You see that cannot bind, cannot inactivate C3b because if you don't bind to C3b and glycosaminoglycan, this does not activate factor I. And then you have the formation of C5 convertase that result in C5 benign formation. Next slide. 50 to 60% of these patients, next slide, have different mutation. If you give me the next slide, it shows that 50% of these patients is associated with mutation in factor H, factor I, gain of function of C3, MCP, and thrombomodulin, and also you may have C factor H antibody in only 8% of patients. Next slide. The same mutation do not translate into the same phenotype because those of different patients exactly with the same mutation that may have a good outcome or a bad outcome, including end-stage renal disease or death, recurrences or not, and also in transplantation, you have someone who have failure and other good outcome. Next one. This shows the case of gene polymorphism in carrier of pathogenetic variant to explain disease penetrance. Disease penetrance is incomplete because in this particular case of this family, you have many members of the family, the square, the little square in blue, in which you can have the factor H mutation, but this is not enough to generate the disease. In order to generate the disease, you have to have this mutation in this particular family and this risk haplotype. Those who have only risk haplotype don't have the disease. Those, that is these propositus in this family that have both the risk haplotype and the factor H mutation, they do have the disease. Next time. Next slide. You may have hybrid genes. This is an example of an hybrid genes formed by the first 19 short consensus repeat of the molecular factor H associated with the 20 repeat that is coming from a factor 8 related antigen. High degree of sequence identity between the gene of factor H and the genes for factor H related 1 and 5 fibers, non-allelic homologous recombination resulting in these hybrid genes. Next slide. È rimasto caso una mezz'ora fra una slide e l'altra. Next slide. Beh, speriamo che si sia interrotto del tutto, almeno dice questa imbuffonata qua. May I have the next slide? Siamo
Professor Ramosi, is the slide appearing with you in the computers or doesn't appear?
Pardon?
Is the slide clear? You can see it?
Yeah, it's clear, but there is a big interruption. Anyhow, let's start from this showing long-term outcome. You see it's very poor. Next slide. But now we have a next slide. Next slide. We have an antibody that binds factor 5. It's called eculizumab. You can see the antibody in the next slide. Okay, here there should be an antibody that binds to factor to C5. Next slide. And this antibody given to patients results in a dramatic increase in platelet count and an increase in estimated GFR, very effective. Now you see that after this antibody was introduced, next slide, in clinical practice, next slide, next slide, you see that the prognosis of this patient, go back, you see that the prognosis of these patients with factor VIII mutation given eculizumab was completely different as compared to when this antibody was not available. Extremely effective. Next slide. But extremely costly. Next slide. You see 300,000 euro per patient per year in child. Next one. Next one. So we wonder whether, as the company says, we have really to treat patients every 15 days forever, or there is any way to monitor the effect of the drug and possibly taper the drug. We have created this test in solid phase. Remember that a typical HOS is a disease of solid phase complement activation. We have microvascular endothelial cells incubated with control or HOS serum. In normal serum resting endothelium, you don't see any deposition, but resting endothelium exposed to acute HOS serum, you see a massive deposition of C5b9 C3b. You can activate endothelium. In this case, you can some deposition in normal serum, but in activated endothelium, HOS serum in remission or serum from asymptomatic carrier of the disease, asymptomatic carrier of the disease, shows sign of deposition of C3b and C5b9. So it's a quite useful test. In order, next slide. To document the disease activity, you see in resting endothelium in acute phase, you have deposition of C5b9. In remission, you can see no longer deposition of C5b9. So the test gives you an idea of disease activity. In activated endothelium, give you an idea of complement dysregulation, because the disease is positive in acute phase and also positive in remission, showing that the test tells you here there is a complement dysregulation. Next. If you give eculizumab to the patients, you see that C5b9 formed before eculizumab dramatically normalized in all patients in this particular test, while if you use plasma C5b9, this is an erratic disposition pre-eculizumab and post-eculizumab give you no idea. So there is no significant change whatsoever in plasma C5b9, while the solid phase test give you exactly an idea if you do the test pre-eculizumab and post-eculizumab. Next slide. The test help to taper and discontinuation eculizumab, because as soon as you taper eculizumab or discontinuate eculizumab, you see in the test that some patients start to form C5b9, and those patients are patients that do relapse after the continuation of eculizumab and need to be retreated at that particular moment. But there is no problem for the patient as soon as you know that while you are tapering and discontinuing your drug, this in fact shows activation of C5b9 formed in the endothelium. Next one. Here you see a patient that after eculizumab had no positive test for as long as 8 weeks, showing that there is no necessity to give eculizumab every 15 weeks as soon as you have this test available that tells you when the disease starts to reappear again. Next one. Okay. Next one. Okay, this is a patient instead that after 6 months had a reactivation of the disease, needed to be retreated, and next one, the activation of the disease in the test appeared before clinical sign of recurrence. So the test is very useful. May I have the next one? Here you have the activation of C5b9 on endothelium before clinical signs were evident. So 1 month before, it tells you that you have to follow your patient very carefully. Then you have laboratory abnormality, zero haptoglobin, for instance, and the test is, of course, again positive. Next one. And we gave eculizumab again, and the test normalized. Next one. We have seen that already. Next one. This is a patient from Vietnam that went to Bangkok, Hong Kong, Sweden, and then came to us. Next one. He wanted to have eculizumab and a kidney transplantation because he said from the brother, because he said my brother had no abnormality. Next one. Actually, he has a mutation in C3, the propositus, and a variant in factor H that was associated with the disease. One daughter had the mutation in C3 while healthy. The same mutation of the propositus had the other daughter, but the brother had no mutation. So he wanted to have the kidney from his brother who had no mutation. We confirmed that, in fact, the brother had no mutation. Next one. But when we did the test on the brother serum in activated endothelium, we found very positive, despite no mutation and no variant. So we decided that this patient could not be transplanted. The next one. And here is a new drug that is now available called ravulizumab that can be given every 8 weeks instead of every 2 weeks. This is very important, particularly for child that may have a problem of venous access. This drug induces complete TMA remission in up to 80% of patients, normalized platelet count in a substantial number of patients, and improve renal function in the trial that has been done so far. Next one is an electron microscopy picture that shows finding of HOS and MPGN in the same patient. This is just to pass from a typical HOS to MPGN. Next one. Next one. As opposite to acute HOS, that was a disease of solid phase complement activation, MPGN is a disease of fluid phase complement activation. And in fact, the regulatory domain, when is mutated, is unable to regulate C3 convertase. Next one. So remember that MPGN is a disease of fluid phase complement dysregulation, as opposite to a typical HOS. Next one. Next one. Next one. The old classification of MPGN type 1, 2, and 3 were based on electron microscopy, where type 1 was subendothelial deposits, type 2 was then deposit disease, type 3 was both subendothelial deposits and subepithelial deposits. Next one. SETI and co-workers have proposed a new classification. MPGN could be classified as IC-mediated when in immunofluorescence you see immunoglobulin in large amount and very modest presence of C3, or C3 glomerulopathy when you see in immunofluorescence a large amount of C3. C3 glomerulopathy can be divided based on electron microscopy on C3GN, C3 glomerulonephritis, and DDD. Electron microscopy did not allow to distinguish between the two forms. Next one. Next one. We have a huge registry of this ultra-rare disease as well. Consider that we have more than 500 patients. That is a lot for a rare disease like that. Next one. Next one. Here, the mutation carrier of the same genes as reported before are, however, only 18%. Again, you have mutation in C3, factor B that are gain of function, factor H, and thrombomodulin. Next one. There was always a killer like Jack the Ripper in the nephrology field. And this killer, next one, is called C3NF. What is C3NF? People were not aware of what C3NF was for many years. Next one. Next one. Now we know that C3 and F are a group of antibodies. It's an heterogeneous family, you see various color, that stabilizes the C3 or C5 convertase complexes. C3F bind to assembled C3 convertase and prevent its spontaneous or factorase mediated decay. C5F bind to assembled C5 convertase and prevent its spontaneous and factorase mediated decay. Next one. We inspire our studies on this particular study, saying that psychiatry need mathematics, also nephrology may need mathematics, and what we have done. Next slide. Was create a cluster analysis. Imagine that this is a group of fruit. Fruit is patients who have deposition of C3 in immunofluorescence in their glomeruli in various degrees. Then you can divide in cluster. The two more similar belong to the same cluster. Another cluster is actually different, but not too much. We have another cluster with two very similar kind of fruits, and the fourth is extremely different. Following this scheme, what we have done was select, next slide.
Professor Ramosi, 3 minutes remaining.
Yeah, we have select 333 patients, excluding secondary MPGN, only primary MPGN, divided by IC-MPGN and C3 glomerulopathies, then divided in C3 glomerulonephritis, and then deposit disease. Next one. Next one. Based on many clinical feature, histological finding, complement profile, and genetic data. Next one. We created the next one, 4 clusters. Next one. 4 clusters. Next one. In all the cluster, we have glomerular C3 deposit, like the basket of fruit. And then you have the 2 clusters that are more similar, the one a little bit different, the one completely different in terms of mutation of ORC3F, serum C3, plasma, glomerular, IgG, or complement, and so on. Next one. This classification, next one. Next one. Next one. Che cagata pazzesca. Cioè, è veramente inutile che uno venga qui, si alza alle 6 del mattino di domenica per fare una puttanata del genere dove c'è sempre fretta. Io mi sono rotto i coglioni, basta, non facciano loro. Se io devo star lì poi ti devono dire esattamente quanto tempo c'è e poi o muoviamo le slide noi o se no gli diciamo che noi non facciamo più niente. No, basta dire che noi non facciamo più niente se non cambiamo le slide noi, basta. Questo brioche, spero poi mangiare il buio, non lo mangio, perché dopo non sto bene.
Professor Ramosi?
Yeah.
Yeah.
No, I think that now the 3 minutes are over. I would like to show to you the critique and our response to the critiques that were very interesting. But unfortunately, the majority of time was lost changing the slide. So I don't know what to do. Tell me what I have to do, because now I am confused. I think that we don't have time left any longer. Hello?
Okay, so
Hello?
we'll open the floor now for the question for the last 2 lectures.
Now, give me the last slide, just to complete what I have to say. These were the critiques, very interesting. It's a shame that we lost all this time. Cluster 1 allow you to, since it's a fluid phase alternative pathway, C3 and C5 convertase activation, you need drug that inhibits simultaneously C3 and C5. For instance, C5a inhibitor, eculizumab, or 5 factor B inhibitor. Cluster 2 is fluid phase, C3 and C5 convertase activation plus classical pathway. So you need to block C3. You see that cluster classification is very important and very sophisticated to give you the idea of which kind of drug you can use for these patients. Now that we have so many drugs, a drug that blocks C3 can block simultaneously C3 and C5 convertase and the classical pathway. For cluster 3, that fluid phase alternative pathway activation and C3 convertase activation only, you can have a factor B inhibitor, iptacopan, or danicopan, that is a factor D inhibitor. For cluster 4, that shows you solid phase complement activation, you need to inhibit complement in solid phase. So the drug that you have available that can do that are an anti-C3d monoclonal antibody, which localize the size of complement activation and is associated with factor H that can inhibit complement activation exactly where is activated in solid phase. And also you have a factor H potentiated antibody. I think I finished. Thank you very much.
Thank you very much for wonderful and enlightening talks for the last 2 lectures. So the floor is open for any questions. So if you allow me, Professor, you talk about the eculizumab and the long-acting C5 inhibitor rivoluzumab. I'm not sure if there is any experience for rivoluzumab in post-transplant era, the long-acting C5 inhibitors?
Not that I am aware. Studies are conducting now. But I don't think we have the results now. And actually, the only advantage is that you can administer every 8 weeks. But as I show it to you, if you do our system to monitor the activity of C5b9 on solid phase, you can have also administration of eculizumab, which is not every 15 days, but is much more prolonged.
Okay, thank you. As long as there is no more questions,
Okay,
we'll
thank
move.
you very much. Thank you.
Thank you, Prof. Thank you for the informative,
Thank you.
detailed presentation.
Thank you very much.
So we'll move to the next speaker, Dr. Kazumoto Lojima. He is a professor at Kobe University Graduate School of Medicine. His research interest mainly in pediatric congenital disorder with special interest in nephrotic syndrome. He will give us part of his experience in the treatment of complicated, frequently relapsing steroid-dependent nephrotic syndrome.
Thank you, Chairman. Yes, can you hear me?
Yes,
Okay.
yes,
Oh.
it's clear.
I'm deeply honored to have the opportunity to give a lecture in this conference. Today, I will talk about the treatment for complicated, frequently relapsing or steroid-dependent nephrotic syndrome, especially rituximab therapy and mycophenolate mofetil maintenance therapy after rituximab for these conditions. Next slide. This is my disclosures. Next slide, please. So complicated frequently relapsing or steroid-dependent nephrotic syndrome, complicated FRNS-SDNS, is a condition of childhood onset difficult to treat nephrotic syndrome. We defined complicated FRNS-SDNS as frequent relapses or steroid dependence under or after several immunosuppressive treatments, which may account for 20 to 30% of childhood onset nephrotic syndrome. And pediatric nephrologists all over the world have recognized the need to develop new treatments for these conditions. Next slide. Next slide, please. Next slide, please. Wow. これはひどいな。Next slide. Next slide, please. Next slide, please.これはひどい。これはひどい。これはひどい。Next slide, please. Next slide, please.
Professor, do you want to go back to the second slide in the beginning? Would you like to go back?
No, oh, okay. So yes. And now second slide, yes, third slide. No. Go back. Oh, okay. Yes. No. Next. This is first, yes. Next slide. Okay. So since the early 2000s, several studies suggested that rituximab, an anti-CD20 monoclonal antibody, is effective as a treatment of complicated FRNS SDNS. Next slide. Next slide, please. Okay. Bentz et al. Reported in 2004 for the first time the efficacy of rituximab for complicated SDNS. In this report, rituximab treatment of a child with both complicated SDNS and idiopathic thrombocytopenic purpura resulted in the long-term remission of both diseases. After this work, several case reports, case series, and the short-term RCT suggested that rituximab treatment enabled most patients with complicated FRNS SDNS to discontinue or reduce steroids and or immunosuppressive drugs without relapse. Among those, I will introduce our study carried out in Japan. Next slide. Okay. In this study, 12 children with complicated FRNS SDNS were treated with single-dose rituximab. After the rituximab treatment, all patients were able to discontinue steroids. The frequencies of relapses significantly decreased and the steroid-free periods significantly increased after the rituximab treatment. And mild infusion reactions were observed in 5 of 12 patients, but we did not experience any serious adverse events in this study. Next slide. So we therefore considered that rituximab may be effective for children with complicated FRNS SDNS. Next slide. In 2007, the use of rituximab was approved only for CD20 positive B-cell non-Hodgkin's lymphoma, NHL, in Japan. It was approved for chronic lymphocytic leukemia, CLL, rheumatoid arthritis, as well as NHL in other countries such as United States. But it was not approved for nephrotic syndrome in any countries. Next. So, to avoid off-label use of rituximab, well-designed clinical trials for drug approval were necessary. Next slide, please. So we conducted a multi-center, double-blind, randomized placebo-controlled trial to confirm the efficacy and safety of rituximab for complicated FRNS SDNS in children. This trial was investigator-initiated clinical trial which sought to gain approval from the Japanese government to make rituximab available for patients with childhood onset complicated FRNS SDNS. Next slide, please. Yes, this slide shows the experimental intervention of this trial, namely RCRNS01. Candidates with relapsed nephrotic syndrome were screened for the eligibility to this study, and simultaneously, they were treated with standard prednisone regimen. When the patients showed complete remission, they were randomly assigned into rituximab group or placebo group. Within 2 weeks after the randomization, the patients were treated with rituximab 375 milligram per square meter, maximum 500 milligram once weekly for 4 weeks, or placebo. prednisolone treatment was withdrawn within 10 weeks, and immunosuppressive agents, including cyclosporine, were withdrawn by week 25, and the patients were observed for 1 year. The patients were considered to have treatment failure if relapse occurred by week 13, or they still showed frequent relapses, steroid dependence, or steroid resistance during the observation period. The primary endpoint of this trial was relapse-free period. Next. When patients developed treatment failures, the allocation code was urgently disclosed. If patients were treated with placebo, they were able to enter a rituximab pharmacokinetic study, namely RCRNS-02. Next slide, please. So in this trial, 63 patients were screened and 52 were randomized. And 48 patients, 24 in each group, received the intervention and were included in the analysis on intention to treat basis. 4 from the rituximab group and 20 from the placebo group had discontinued the intervention, mostly because of treatment failure. However, no patients dropped out from the study before the first relapse. That was the primary endpoint. And all the patients with treatment failure in the placebo group were enrolled into a separately conducted rituximab pharmacokinetic study after discontinuation or completion of this trial. Next slide, please. This slide shows the primary endpoint. The median relapse-free period was 267 days in the rituximab group, whereas 101 days in the placebo group. So the difference was statistically significant. Next slide, please. The time to treatment failure in the rituximab group was significantly longer than in the placebo group. Next slide, please. The relapse rate, that is the number of relapses per person year during the trial period, was significantly lower in the rituximab group than in the placebo group. Next. Daily steroid dose after treatment in the rituximab group was significantly lower than in the placebo group. Next slide, please. The majority of adverse events reported were mild. No deaths were reported in this trial. Although the rate of serious adverse events was higher in the rituximab group compared to the placebo group, this difference was not statistically significant. And 79% of patients in the rituximab group showed a mild infusion reaction, whereas 54% of the patients in the placebo group also showed mild infusion reaction. So the difference was also not statistically significant. Next slide, please. The frequency and the severity of infectious diseases to need treatment was similar in both groups. Next slide. However, the frequency of infection was significantly increased during B-cell depleted period in rituximab treatment. Next slide, please. So we concluded rituximab is effective and safe at least for 1 year for the treatment of childhood onset complicated FRNS SDNS. Next slide, please. Based on the result of our study, the use of rituximab for patients with complicated FRNS SDNS was approved by the Ministry of Health, Labor, and Welfare, Japan on August 29, 2014. Next slide, please. In recent Cochrane database of systematic review, Larkins et al. Reported rituximab may be a valuable additional agent for the treatment of frequently relapsing nephrotic syndrome, where relapses persist despite treatment with other non-corticosteroid agents. So I think rituximab is recognized as a standard treatment for patients with complicated FRNS, SDNS, although its use remains off-label outside Japan. Next slide, please. However, rituximab is by no means a magic drug. We carried out RCRNS and RCRNS-01 and RCRNS-02 follow-up study and found only 3 of 51 patients, it's just 6% of the patients showed long-term remission. And 30 patients, it's 59% of the patients developed FRNS, SDNS, and were treated with immunosuppressive agents again. And 22 patients, it's 43% of the patients needed retreatments with rituximab. No patient developed severe infection or malignancy so far. Next. So we considered further modifications of rituximab treatment, including adjunct immunosuppressive therapies and repeated courses of rituximab are necessary to extend the relapse-free period. Next slide, please. Because the safety of long-term B-cell depletion caused by repeated administration of rituximab in children with developing immune systems was unknown, we believed a new maintenance therapy for the prevention of relapse after rituximab therapy was urgently needed. And our group conducted a pilot study and reported maintenance therapy with mycophenolate mofetil, MMF, after rituximab in children with complicated SDNS significantly prolonged the relapse-free period compared with rituximab monotherapy. Next slide, please. So we conducted a multi-center, double-blind, randomized, placebo-controlled trial, namely JSKDC-07, to confirm the efficacy and safety of MMF after rituximab for children with complicated FRNS SDNS. Next slide, please. This slide shows the experimental intervention of the trial, namely JSKDC-07. The candidates with relapsed nephrotic syndrome were screened for the eligibility to this study, and simultaneously they were treated with the standard prednisone regimen. When the patients showed complete remission, they were randomly assigned into MMF group or placebo group. And within 2 weeks after the randomization, the patients were treated with rituximab 375 milligram per square meter, maximum 500 milligram once weekly for 4 weeks, MMF at the dose of 1,000 to 1,200 milligram per square meter per day, maximum 2 gram per day, or placebo was administered until day 505. It's week 73. And prednisone treatment was withdrawn within 10 weeks, and immunosuppressive agents, including calcineurin inhibitors, were withdrawn by week 25. In this trial, the follow-up period was defined as the time from day 506 to day 505 of the last enrolled patient. The primary endpoint of this trial was defined as the time to treatment failure during the combined treatment and follow-up periods. And treatment failure was defined as the development of frequent relapses, steroid dependence, or steroid resistance, or use of immunosuppressive agents or rituximab. Next slide, please. Of 137 patients assessed for eligibility, 86 were randomized. In total, 78 patients, 39 in each group, received intervention and were included in the full analysis set. The baseline features of patients were similar between the two groups. Next slide, please. This slide shows the primary endpoint. In the MMF group, the cumulative treatment failure-free probability was 84.6% at day 505, whereas in the placebo group, it was only 44.7%. However, the effect of MMF disappeared after its discontinuation, resulting in many relapses after the treatment period, which led to treatment failure during the follow-up period. Next slide. As a result, the effect of MMF was not statistically significant in the present trial. However, the post-hoc analysis limited to the treatment period showed MMF following rituximab reduced the risk of treatment failure by 80%. Hazard ratio was 0.202 during MMF administration. Next slide, please. Moreover, the analysis of relapse rates during the treatment period, which was a poorly defined secondary endpoint, revealed MMF following rituximab decreased the relapse rate during MMF administration by 74%. Hazard ratio was 0.257. Next slide, please. Also, daily steroid dose during the treatment period, which was another secondary endpoint, significantly decreased in the MMF group than in the placebo group. Next slide, please. The incidence of adverse events was not statistically significantly different between the two groups. No deaths were reported in this trial. And as you can see in this slide, regarding the grade 3 to 4 adverse events, there was no significant difference between the two groups. So, regarding the safety profile, MMF following rituximab was well tolerated. Next slide, please. In summary, administration of MMF after rituximab may sufficiently prevent the development of treatment failure and is well tolerated, although the relapse preventing effect disappears after MMF discontinuation. Next slide, please. In conclusion, MMF maintenance therapy after rituximab may be an option for sustaining remission in children with complicated FRNS-SDNS, although its benefit remains to be statistically proven. And further studies are necessary to examine the efficacy and safety of long-term MMF maintenance therapy after rituximab in children with complicated FRNS-SDNS. In addition, further studies are needed to clarify the pathogenesis of idiopathic nephrotic syndrome to develop curative therapies rather than those that sustain remission. Next slide. This is my final slide. I would like to express my great thanks to my colleagues shown in this slide, as well as members of RCRNS and JSKDC. And also, I would like to express my special thanks to patients and their legal representatives who participated in our clinical trials. Thank you for your attention.
Thank you very much, Professor Kuzumoto, for wonderful overview of using rituximab on those type of kids with frequently relapsing nephrotic syndromes. The floor is open for anyone have questions. Any questions? Go ahead, Dr. Abu Bandar.
Thank you for this nice talk and presentation. Just would like really to know your what you do in terms of the protocol when you are using rituximab. How frequent you repeat the doses? And the second question regarding the rituximab in case of steroid-resistant nephrotic syndrome. In our experience, we had some cases who really showed some response, even still partial response. Thank you.
Mm-hmm. Okay, the first question is why we use the 4 doses of rituximab. That's right? Actually, yes. Our clinical trial is the very first clinical trials of rituximab for nephrotic syndrome. So we discussed about the study design of this trial with officials in charge of PMDA. I mean, it's Japanese FDA many times. And actually, they recommended us to use the 4 doses of rituximab. Maybe it because yes, it's already approved for the non-Hodgkin's B-cell lymphoma in Japan. So we utilized 4 doses in this trial. Okay, and the second question is that maybe the use of rituximab for steroid-resistant nephrotic syndrome, right? Yes, actually we carried out the single arm of clinical trial to examine the efficacy and the safety of rituximab for very complicated steroid-resistant nephrotic syndrome. And actually, yes, about 4 to 5 of 6 patients showed complete remission after the rituximab and methylprednisolone PAR therapy. So I think rituximab is also effective for at least a part of patients with severe steroid-resistant nephrotic syndrome. But we know the only one randomized controlled trial of rituximab for steroid-resistant nephrotic syndrome, which showed no effect of the rituximab for those patients. So actually, it's controversial.
Thank you very much. I think for the resistant type, the key rules probably the genetic testing. If the genetic testing is positive, likely, most likely, no any immune suppressive therapy gonna be work. That's why usually we don't give anything. And that's what we IBNA guidelines have been mentioned in steroid resistant. Any more questions? Okay. Do you think going with the same question that Dr. Al-Anezi mentions, do you need to go for all the 4 doses of rituximab, although the CD19 and 20 is 0 after the first dose? You know, some of patients, whenever you give them 1 dose of rituximab, they have sustained CD19 and 20 to be 0. So probably doesn't need to give another dose of that. What do you think about it?
It is a very difficult question. Actually, we should carry out the clinical trial to compare the so lower dose or high dose something. But actually, yes, in our clinical practice, we often use 1 dose or 2 dose, and it's actually effective. So maybe 1 or 2 doses sufficient to induce the relatively long-term remission in the steroid-sensitive nephrotic syndrome, I think.
Very much. No more questions. So thank you very much, Professor Kumamoto, and thank you for joining us today, and hopefully we'll have you again for our next future meetings. Thank you very much.
Thank you very much.
So we'll move on for the concerns of the times to go to the third speaker for our plenary sessions, and who's the Christopher Warner, who's a well-known nephrologist. He's a professor of medicine and chief of division of the nephrology and hypertension at the University Hospital of Würzburg in Germany. He has tons of publications in his part of interest. He will talk today about a new approach in the, to retard the progression of the CKD. So, Professor Wanners, the mic is yours. I don't know. Yeah, excellent. So you are with us. So most welcome to our conference. So the mic is yours, professors.
Thank you, and for this kind introduction, and of course, my greetings to Riyadh and the Saudi Conference of Nephrology. So I understand that you will advance my slides, or should I do it? Anyway, I see my slides, so I think I continue.
Whenever you need to just change the slide, ask them and they will change it here. So they will control changing the slides.
So first of all, I'm working also in trials which are in the field of nephrology. And here is my transparency declaration. And next slide, please. So in nephrology, we are currently building up a temple of the management. And we have already developed 3 pillars in just recent time, and you see that the basic is RASI, the blockade of the renin-angiotensin system, and moreover, we have now the SGLT2 inhibitors as standard of care, and we also introduced just recently in some countries, not all in the world, but it is coming, the mineralocorticoid receptor antagonism, currently with finerenone. And when you, next slide, click, the inset shows you the future, and the future may be a GLP-1 receptor agonist with a trial flow in about 1 year, with atrasentan, which is currently developed, an endothelin receptor antagonist, and maybe also the aldosterone synthase inhibitor and the soluble guanylate cyclase activator, which may be therapies in the future for management of diabetic kidney disease. So next slide, please. You see the next slide. That these data have already found a way into guidelines, and Kidney Disease Improving Global Outcome is our global guideline body. And next slide, click, please. The science is global, but implementation over the world is local. So next slide, please. We go to the holistic approach KDIGO is offering to us nephrologists, and the improving the outcome in patients. And at the beginning, on top, you always have lifestyle interventions. We always do, with different success. And in the first line treatment is an SGLT2 inhibitor. It should be started with above GFR of 20 and not stopped until treatment. And this is standard of care today. in the treatment of diabetic kidney disease. But there is also for type 2 diabetes, in green, there is the other treatments with metformin on eyesight, best in combination, and then other intervention such as blood pressure lowering or a statin for atherosclerotic cardiovascular disease. So next slide shows you again the treatment algorithm with physical activity at the beginning, and then metformin, which should be stopped due to lactic acidosis at the glomerular filtration rate of 30, and then an SGLT2 inhibitor above GFR of 20, the start and not stopping until dialysis. If you have further treatments necessary to stabilize blood glucose control, then the next agent preferred is a GLP-1 receptor agonist. Next slide, please. So the data overall which are out there, the totality of evidence is consists of 3 types of SGLT2 inhibitor studies. On the top, there are the cardiovascular outcome trials with in type 2 diabetes. On the right-hand bottom, there are the heart failure outcome trials now completed for HFpEF and HFrEF, and all trials positive. On the left-hand side, the kidney and the primary outcome, and all these kidney trials have been stopped early for overall benefit. So next slide. So the insert says kidney in the primary outcome. Next slide. And for the other trials, the kidney in the secondary outcome, and you only get something from regulators when the kidney is in the primary endpoint, and we have these trials. So next slide, please. Recently, about 5 weeks ago, a meta-analysis has been published in The Lancet about the impact of diabetes on the effects of sodium glucose co-transporter inhibitor on kidney outcomes, a collaborative meta-analysis of all the 13 trials we have seen. Next slide. And this slide shows you the totality of evidence so far. On top, in yellow, you see all trials with type 2 diabetes. In blue, on the bottom, you see all trials with non-diabetic patients. And on the left-hand side, all the names of the trials we have seen over the years. Second row is the glomerular filtration rate. And of course, if you go down in the yellow part, you see DAPA-CKD and EMPA-Kidney. And all these trials have been made similar with the primary outcome. So we are looking at 50% decline of kidney function and dialysis or end-stage kidney disease. And DAPA-CKD and EMPA-Kidney showed the same result, about a 40% relative risk reduction. And this is so surprising for us nephrologists that we get out from SGLT2 inhibition twice as much as we get from renin-angiotensin inhibitor treatment. Overall, the effect on the kidney outcome is so consistent with all the data points and point estimates lining up nicely below and showing the overall benefit of the SGLT2 inhibitors, irrespective of the underlying pathophysiology of heart failure or cardiovascular outcome or the kidney trials. Kidney is responding in the same way, and SGLT2 inhibitors are today's standard of care. Next slide, please. So we are looking on the meta-analysis, the characteristics of the 13 included trials. On the left-hand side, type 2 diabetes, heart failure, chronic kidney disease, the number of trials. The mean eGFR goes down when you enrich the population by chronic kidney disease. Then you see the median follow-up relatively short for type 2 diabetes and chronic kidney disease trials. And then the number of patients without diabetes. So we investigated patients with glomerular diseases also in the trials with chronic kidney disease. And we have studied 90,000 patients in randomized trials. And I think we do not see a lot of surprises anymore in the future. Next slide. So here you see the kidney disease progression divided into diabetes and no diabetes. And the many patients went into these trials and the number of events are high. So the drug, the SGLT2 inhibitor, works in patients with diabetes and without diabetes. Next slide, please. Here you see kidney disease progression by diagnosis. On the top is diabetic kidney disease, all the trials lining up really beautifully with point estimates, one below the other. Then we have patients with hypertensive diseases, ischemic and hypertensive. It works there. Patients with glomerular diseases, point estimates left of unity, and also other diseases nicely shown with the point estimates. Next slide, please. Here we see the kidney disease by progression by glomerulonephritis. And one glomerulonephritis is IgA nephropathy. There were 800 patients in EMPA-KIDNEY and 200 in DAPA-CKD. And you see that the point estimate is left of unity. So in the future, with a 50% relative risk reduction, we treat IgA nephropathy before we apply immunosuppression. And it will become also standard of care in patients with IgA nephropathy. There are low numbers of focal segmental glomerular sclerosis. So apparently you have to look at the entire result, and other glomerular diseases respond as well to the SGLT2 inhibitor. Next slide, please. There are signs of acute kidney injury. No, apparently not. The point estimates are left of unity. In patients with diabetes and no diabetes, kidney patients are protected from acute kidney injury with a 23% less relative risk in all the global trials. Next slide, please. We are looking on cardiovascular deaths or hospitalization for heart failure here, and an SGLT2 inhibitor works in patients with diabetes and no diabetes in relation to these outcomes. Next slide. There are signs of ketoacidosis and amputation. Yes, ketoacidosis is the complication in the room, but it's twice as high from the relative risk. But look at the number of patients who develop ketoacidosis in diabetes patients. There are 70,000 over there, and only 160 will develop diabetic ketoacidosis. However, if you are living in a town like Riyadh and you treat about 10,000 diabetics with an SGLT2 inhibitor, the hospital in Riyadh will have 1 or 2 diabetic patients on the intensive care unit per year with diabetic ketoacidosis. It doesn't happen in patients without diabetes. Lower limb amputation was discussed. And there's a 15% relative risk reduction, but it occurred mainly in the CANVAS trial by a play of chance. If you take on the bottom of the data, the CANVAS trial out of the equation, then you can see that there is no significant sign anymore for lower limb amputation, and we do not consider it as a side effect. Next slide, please. We are looking on the overall predicted absolute effect per 1,000 patients years On the left-hand side, patients with diabetes. On the right-hand side, without diabetes. In blue, you see the reduction in the number of events in respect to kidney disease progression. In red, you see acute kidney injury reduction. In green, the reduction in cardiovascular death and hospitalization for heart failure. And this balances nicely out the ketoacidosis or a potential lower limb amputation. And you see a positive signal here. Next slide, please. So the implication of all available evidence for SGLT2 inhibitors in this meta-analysis is telling us that the analysis provides high-quality evidence to support a guideline recommendation for the use of SGLT2 inhibitors as a foundational therapy to reduce the risk of kidney disease progression and acute kidney injury, not only in patients with type 2 diabetes at high cardiovascular risk, but also in patients who have chronic kidney disease or heart failure, irrespective of diabetes status, primary kidney diagnosis, or level of kidney function. Next slide. We are coming now to the SGLT2 inhibitor paper before I go to other treatments, which was published online November 4, 5 weeks ago, and which forms also the totality of evidence. Next slide. So the EMPA-KIDNEY was a double-blind placebo-controlled trial in a very broad patients population, in patients with kidney disease, and a third were non-diabetic kidney disease, a third diabetic kidney disease, and a third was for the discretion of the investigator. Next slide. The primary composite outcome was a composite of cardiovascular death and kidney disease progression. And here we see kidney disease, end-stage kidney disease as an endpoint, or a decline in glomerular filtration rate by about 40% was the composite. Next slide. We see that patients with an eGFR above 20 to 45 were included, and these patients were not necessarily with albuminuria, so unalbuminuric or low albuminuric patients, and those with an eGFR 45 to 90, they have to have albumin creatinine ratio of above 200 milligram per gram. Next slide. Here you see the baseline characteristics of the 64-year-old patients, more male than female, more patients without diabetes, 54%. The mean eGFR was 37, so quite low, and the mean UACR was 300. Median follow-up of the entire trial, only 2 years. The trial was stopped because of overwhelming benefit. Next slide. Here you see the primary composite outcome with the Kaplan-Meier survival curve, and the curves are opening up after 1 year. You see the number of patients with placebo and the number with empagliflozin, and there was a relatively risk reduction of 28%, a narrow confidence interval. So very significant results in the EMPA-KIDNEY trial. Next slide. Then we look at components of the primary outcome. Only kidney disease progression, 29% here. Next slide. And on the right-hand side, we see cardiovascular death. It was interesting and surprising to note that there were not many cardiovascular deaths, and therefore, because there were only few, no significant result was obtained. Not enough power in the trial. And why were there no cardiovascular deaths? Because we are looking at relatively young patients also with non-diabetic kidney disease, and in Asia, which have no a cardiovascular death rate or a very low rate. Next slide. We look in the next slide on the end-stage kidney disease on the right-hand side and cardiovascular death, and there was a significant reduction in this endpoint. Next slide, please. Here you see primary diagnosis by diabetes.
Professor Warner, 3 minutes remaining.
Yes. Patients with diabetes and no diabetes, and there was no difference. Next slide, please. Hello? Next, please. The primary outcome by albuminuria was very interesting. And in the group with low albuminuria, you see that the point estimate is moving to unity. So apparently, there was a higher effect of empagliflozin in patients with high albuminuria or very high albuminuria. So next slide, please. And we are looking mainly to explain this result with little or less effect in the low albuminuria group on the slopes. Here you see the decline initially dip in glomerular filtration rate, then stabilization over time. The relative reduction of the slope progression was from 2.75 ml per minute per year to 1.37. So by 50% reduction in the progression. You see the curves are crossing at about 18 months. And when we apply these slopes now to the categories of albuminuria, and next slide, please. The chronic eGFR slopes by albuminuria shows, for example, in those with low albuminuria, first line, below 30 milligram per gram, they have a slow progression by 0.86 mil per minute per year. But you can reverse this progression even in those who are slowly progressing to 0.11, so a null slope. This is no progressive diseases. So actually, when you are faster progression by 4.11 ml per minute per year, then you can reduce it in the range of 2. So that's a very interesting result. You can reduce the progression, but those with low albuminuria takes a long time to reach a hard endpoint. You cannot show it with the hard endpoint. Next slide, please. We then are going to the safety outcomes. Again, chronic urinary tract infection, hyperkalemia, acute kidney injury, ketoacidosis, and the lower limb amputation. There were some ketoacidosis, 6/1 in this large patient group, but overall no sign of concern here with the safety outcomes, and here they are the most prominent. Next slide, please. So we are now coming to another part, the next line of treatment, which is a non-steroidal mineralocorticoid receptor antagonists for type 2 diabetics with residual albuminuria above 30 milligram per gram. It is recommended by KDIGO guidelines to use a non-steroidal MRA, which is currently finerenone. So on what data is this recommendation based? Next slide, please. And the slide shows the recommendation that we suggest a non-steroidal MRA with proven kidney and cardiovascular benefit for patients with type 2 diabetes, an eGFR above 25, normal serum potassium concentration, and albuminuria above 30 milligram despite maximum tolerated dose of RAS inhibitor. Next slide shows the trial finerenone, the Fidelio trial on the left-hand side, the kidney outcome, kidney failure, sustained more than 40% decline in glomerular filtration rate, and a dialysis or renal death. And you see a relative risk reduction of 18%, a narrow confidence interval, a robust result, and the curves are opening up at more than a year to 1.5 years, and the number needed to treat is 29. These are also cardiovascular protective treatments, because on the right-hand side, you see the time to cardiovascular death, non-fatal MI, non-fatal stroke, and this is significantly reduced by 14% in patients with type 2 diabetes. Next slide. Here you see another approach, which is another line of anti-diabetic treatment, the GLP-1 receptor agonist, which should be introduced if you have no target values achieved by your hemoglobin A1C. And the data, next slide.
Professor Warner, 1 minute remaining.
Yes, the slide shows that you have a potential to reduce kidney outcomes, and you see all the trials lining up. And if you show the next slide, which takes out the albuminuria and only have kidney disease progression, or with albuminuria, then you have a significant result and more data are necessary for the future. Next slide, please. So my final slide shows that diabetic kidney disease is usually progressing with 6 ml per minute per year, and you give a RAS inhibitor, you can lift up the curve with an SGLT2 inhibitor in yellow, in red even more, and in the future with adding a mineralocorticoid receptor antagonist, you can really push away dialysis by a significant number of years. So I'm coming to the end. Next slide. And I thank you for the attention. Thank you.
Thank you very much, Professor Warner, for wonderful enlightening about the new approach in retarding the progression of chronic kidney disease. The floor is open for any pressing question because we are running out of time. Any questions? Tfadal.
Okay, thank you so much for this interesting talk outlining the evidence for the CKD care, especially the SGL2. My questions regarding the...
Can you raise your voice, Dr. Khalid?
My question for the DABA CKD population and IMBA kidney population. I think they are very different in terms of the proteinuria. And if you can, go to the curve, in DABA CKD and in the IMBA. In the IMBA, it's delayed. It takes like 1 year to show the cardiovascular and the renal benefit. However, it's persists, over the, subsequent 2 years. But what do you think, Prof? Why it's delayed? Is it because of the proteinuria? This is the first question. The second question, how safe those drugs in transplanted patients, especially the diabetic patient who get transplanted?
Yeah, you are correct, a different population. And they are they are progressing at a different rate. If you have lower albuminuria, you progress lower. If you make the endpoint similar, then you see that there is a class effect and both intervention, dapagliflozin and empagliflozin, are similar. So there is no difference, and it all is explained by different population. So in transplant patients, there is a trial which will give us the result in about 3 years. But meanwhile, all transplant centers, at least in Germany and Austria and Switzerland, they use SGLT2 inhibitors and try in a handful of patients. And they have so far, in meta-analysis of 100 to 200 patients, no safety problems. So it works in transplants, but there is still not a lot of data. We will get more data, but I think it works. You could try in some patients, but it is not an official recommendation.
Thank you very much. Any more question? No more questions. So we'd like again to thank you, Professor Warner, for your joining us for our Saudi conference, and looking forward for joining us for future meetings. So thanks you very much, and see you next.
Thank you.
So I think by this we conclude the plenary session for this time. And again, I would like to thank the organizing and scientific committee for organizing such wonderful meetings. So thank you very much.
افتتاح المؤتمر سيكون بعد 10 دقائق من الآن بإذن الله. افتتاح المؤتمر سيكون بعد 10 دقائق بإذن الله. هذا اللي يعطوني. لا انا هذا اللي عندي. يا حبيب قلبي. الترتيب القرآن، وبعدها المقطع التعريفي، وبعدين شركة فريزينيوس، دكتور فيصل، بعدين التقييم. وبعدين انا اللي بدخل القرآن. يس دي ما في مشكلة. السلام الملكي. بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف الأنبياء والمرسلين، نبينا وحبيبنا وقدوتنا محمد عليه وعلى آله أفضل صلاة وأتم تسليم. ثم أما بعد، أصحاب السعادة، السادة الحضور، مشاهدينا الأعزاء، السلام عليكم ورحمة الله وبركاته، وأسعد الله ظهيرتكم وجميع أوقاتكم بكل خير وبركة وسرور. ومرحبا بكم في المؤتمر السعودي لأمراض الكلى، والذي تنظمه وزارة الصحة في الفترة من 11 ديسمبر إلى 13 ديسمبر لعام 2022 تحت رعاية سعادة وكيل الوزارة للخدمات العلاجية الدكتور طريف بن يوسف الأعمى. هذا المؤتمر يستعرض آخر المستجدات في مجال أمراض الكلى في مختلف تخصصاتها الدقيقة، بمشاركة نحو أكثر من 46 متحدث من داخل المملكة العربية السعودية ومن خارجها من النخبة. ويهدف المؤتمر إلى التركيز على عرض آخر التطورات بتقنيات وطرق علاج أمراض الكلى، وإلقاء الضوء على نموذج الرعاية الكلوية الشاملة وخطط التحول الصحي، وأيضاً إضافة إلى جمع المختصين في برامج الرعاية الكلوية لتبادل خبراتهم في جميع جوانب خدمات تشخيص وعلاج أمراض الكلى. وخير ما نبدأ به هذا المؤتمر آيات من الذكر الحكيم.
ألم تر أن الله أنزل من السماء ماء فأخرجنا به ثمرات مختلفا ألوانها ومن الجبال جدد بيض وحمر مختلف ألوانها وغرابيب سود ومن الناس والدواب والأنعام مختلف ألوانه كذلك إنما يخشى الله من عباده العلماء إن الله عزيز غفور.
صدق الله العظيم. تشاهدون الآن حضورنا الكريم مقطع فيديو عن برنامج الرعاية الكلوية.
من منطلق حرص وزارة الصحة على الاهتمام بصحة المواطن ولما يمثله برنامج الرعاية الكلوية الشاملة من أهمية كبرى بصحة الفرد والمجتمع، وبما يتفق مع رؤية المملكة 2030 والتي تعنى برفع كفاءة المواطن السعودي من خلال الاهتمام بالنواحي الصحية للمواطن السعودي، فقد أطلقت وزارة الصحة برنامج الرعاية الكلوية الشاملة للكبار والصغار، وتشمل الرعاية الكلوية الشاملة للكبار أمراض الكلى، برنامج الغسيل الدموي، برنامج الغسيل البريتوني، برنامج زراعة الكلى، وكما تعنى عناية خاصة بتحديث البنية التحتية وتطوير القوى العاملة بالرعاية الكلوية، وبرنامج جراحات الوصلات الوعائية، وذلك من خلال المبادرات والبرامج التي تعنى بكل ما يخص أمراض وزراعة وغسيل الكلى، وبما ينعكس إيجاباً على صحة المواطن. فبلغ عدد المرضى الذين تخدمهم وزارة الصحة أكثر من 14,000 مريض من خلال مراكز الغسيل الكلوي المنتشرة على مستوى المملكة، وعددها 160 مركز غسيل كلوي مشغلة من الوزارة، و63 مركزاً مشغلاً من خلال مشروع شراء الخدمة. ومن أهم المنجزات في هذا المجال افتتاح مركز الأمير عبد المجيد لأمراض الكلى بمستشفى الملك فهد بجدة بسعة 42 كرسي والطاقة الاستيعابية القصوى 168 مريض. تحوير وتطوير وحدة الكلى بمستشفى الرعاية المديدة في خميس مشيط من 3 كراسي إلى 15 كرسي، ورفع الطاقة الاستيعابية القصوى من 12 مريض إلى 60 مريض. الانتهاء من بناء مركز الغسيل الكلوي بمحايي العسير بسعة 20 كرسي والطاقة الاستيعابية القصوى 80 مريض. افتتاح مركز الفوزان للغسيل الكلوي بمستشفى الملك فهد التخصصي ببريدة بسعة 24 كرسي وطاقة استيعابية 96 مريض. افتتاح مركز العليان للغسيل الكلوي بمستشفى بريدة المركزي بسعة 40 كرسي والطاقة الاستيعابية القصوى 160 مريض. افتتاح مركز الغسيل الكلوي بمستشفى شقراء العام بسعة 30 كرسي وطاقة استيعابية 120 مريض. افتتاح مركز عثمان الشهري لأمراض الكلى في بيشة بسعة 30 كرسي وطاقة استيعابية 120 مريض. افتتاح مركزي الغسيل الكلوي بالريث والعيدابي بمنطقة جازان بسعة 12 كرسي لكل منهما وطاقة استيعابية 96 مريض. خدمة الغسيل الدموي المنزلي لأول مرة على مستوى الوزارة بمدينة الطائف. برامج تطوير القوى العاملة التمريضية بمراكز الكلى. عقد عدد 13 دورة تدريبية معتمدة من الهيئة السعودية للتخصصات الصحية. مدة الدورة من 4 إلى 6 أسابيع وعدد المستفيدين 100 ممرض وممرضة سنوياً. ونظراً للجهود الكبيرة لوزارة الصحة وخلال جائحة كورونا تم العمل على رفع مستوى الكفاءة من خلال منجزات أثناء الجائحة بعقد عدد 12 دورة تدريبية عن بعد للتمريض بمراكز ووحدات الكلى. وكان عدد الحضور 2230 ممرضاً وممرضة واستقبال عدد 785 مريض فشل كلوي من مشروع شراء الخدمة مصابين بكوفيد-19 لتلقي الغسيل خلال مدة العزل النظامي. ولحرص الوزارة على تحقيق رؤية 2030 فإن الاهتمام بصغار السن والأطفال يمثل أولوية لدى الإدارة من خلال مستويات تقديم خدمات الرعاية الكلوية للأطفال، الكشف المبكر لأمراض الكلى الأطفال، الخدمات الطبية الأساسية بعيادات تخصصية عدد 16 عيادة، خدمات الغسيل الدموي للأطفال عدد 8 مراكز، خدمات غسيل بريتوني للأطفال بعدد 12 وحدة، مراكز التميز المرجعية بعدد 6 مراكز.
نجدد الترحيب بكم بعد هذا العرض المرئي ونترككم الآن مع كلمة الراعي الرئيسي شركة فرزينيوس، ويتفضل مستر فرانك فاغنر مشكورا.
Dear Honorable Ministry of Health, Deputy Minister Dr. Tarif Alama, Chairman of the Conference, Dr. Yassin Alhamd, Saudi Society of Nephrology. On behalf of our company, Fresenius Medical Care, a warm welcome to all of you. I'm honored and excited to attend this conference in person. Through more than 30 years of partnership with reputable Saudi health institutions like the MOH, we, Fresenius Medical Care, have witnessed the great development of the medical services that meet the highest standards offered globally. With close monitoring of the progress of the 2030 vision, implementation, and ambitious targets, we decided to catch this opportunity to be partner of one of the most promising transformation models in the world that would be a unique chapter of the Saudi healthcare history and as well as success model for the whole region health transformation plans. As a start to demonstrate our commitment, we established our dialysis provider entity in Saudi Arabia with ambitious investment plans of 300 million SAR to establish 20 dialysis clinics in 3 years to be part of the new model of kidney care program in the Kingdom of Saudi Arabia. As we have celebrated early this year the launching of our first dialysis center in Riyadh, I would be highly honored to witness the celebration of our complete start of all our centers as planned to help supporting ESRD patients with the best medical care standards offered through our global network of more than 4,000 centers serving more than 340,000 ESRD patients and offering jobs for more than 1,000 healthcare professionals to share localization of the experience. I visited Saudi Arabia 40 years ago, and I had the honor to meet many enthusiastic, dedicated, well-educated group of men to bring state-of-the-art technology and the best care to Saudi Arabia. 40 years later, here we are competing as renal dialysis manufacturers in living up to the standards required to have a successful and sustainable business in Saudi Arabia. Fresenius Medical Care Saudi Arabia has now a capable company team of Saudi females and males contributing to the effective implementation of the 2030 vision and its transformation plan to deliver value-based, acute and chronic kidney care. I can personally testify through many of my visits and sincere relationships that the transformation is a fact. No doubt, the MOH project will transform the CKD programs to another level, and our company is ready to be part of it. Thank you for giving us the opportunity to be part of your dreams and strategic plans, and we are happy to participate in this important conference. Good luck to all of you. Thank you.
شكرا للراعي الرئيسي على هذه الكلمة. والآن نترككم مع كلمة راعي المؤتمر سعادة الدكتور فيصل الدهمشي وكيل الوزارة المساعد لخدمات المستشفيات، فليتفضل مشكورا.
بسم الله والحمد لله والصلاة والسلام على رسول الله. أخواني وأخواتي الحضور الكريم، أصحاب السعادة، المحاضرين، الحضور، الجهات المنظمة، شكرا لكم من الأعماق. اسمحوا لي في هذه الكلمة القصيرة أن أرسل 4 رسائل شكر وطلب. فرسالتي الأولى ورسالة الشكر والتقدير من راعي هذا الحفل سعادة الوكيل للخدمات العلاجية الدكتور طريف بن يوسف الأعمى، يبلغكم تحياته ويشكركم على جهودكم جميعا. رسالة الشكر الثانية للحضور والمحاضرين. يعني أنا فعلا أول ما دخلت كنت أسأل زميلي الدكتور عبد الله عن الحضور، يعني أنا أحس الرقم اللي أعطاني إياه أقل من اللي قاعد أشوفه أمامي، فشكرا لكم من الأعماق. حضور غفير من مختلف المناطق، نسبة التمثيل الآن 100% من كل مناطق المملكة. محاضرين تجاوز العدد 46 محاضر، 47 جلسة، 26 سيمي أورز إذا حسبنا ورش العمل اللي فيها، 3 أيام من الساعات التعليمية المكثفة مع جميع الخبراء والمختصين في مجال الرعاية الكلوية. شكرا لكم من الأعماق. أتمنى لكم أن يكون هذا ملتقى برودكتيف، منتج، مفيد، في كثير من مشاركة المعلومات ونقل العلم والمعرفة بين بعضكم. فشكرا لكم، وهذه هي رسالة الشكر الثانية. رسالة الشكر الثالثة، أشكر اللجنة المنظمة، يعني وأهنئهم على بوادر نجاح هذا الملتقى، الإعداد، التنظيم، المحاور. وأنا قاعد أقرأ محاور الملتقى فعلا يدعو للاطمئنان أنه جميع المحاور التي تخص المستفيدين من الرعاية الكلوية مغطاة في عرض اليوم وبكرة وبعد بكرة بإذن الله. فشكرا للجان التنظيمية. ما وصل هذا الملتقى لليوم إلا كان في قبله أشهر من التعب والمتابعة والاستمرار في المتابعة لتنفيذ هذا الملتقى، ويكون بالشكل اللي تأملونه بإذن الله، وتخرجون فيه بمخرجات تفيد المستفيدين من الرعاية الكلوية. رسالة شكر الرابعة للجنة الاستشارية لخدمات الرعاية الكلوية. أنا جدا جدا سعدت اليوم وأنا أشوف الصف الأول والصف الثاني جميع زملائي اللي بدأوا في اللجنة الاستشارية للرعاية الكلوية الشاملة في وزارة الصحة. شكرا لكم من الأعماق، هنيئا لكم ما عملتم سابقا وما أثمرتم في مثل هذه الملتقيات والمحافل اللي نلقاكم موجودين فيها اليوم. هذا يدل أنه فعلا وصلتوا إلى مرحلة من الإحسان والإخلاص. شكرا جميع أعضاء اللجنة قيادتهم الدكتور محمد مغربي، الله يعطيه العافية. الدكتور محمد الله يعطيه العافية، أنا ما قاعد أشوفه الآن بس أنا متأكد أنه الله يعطيه العافية الدكتور، يعني فعلا. والزملاء الدكتور بدر حميد، الدكتور محمد العومي، جميع الزملاء أعضاء اللجنة الاستشارية اللي كانوا فعلا في 2019 و20 و21 سنوات كبير كان عملهم بشكل يعني اللي الآن وصلنا له، ترى كان بناء على ثمار كانوا يغرسونها في ذلك الوقت. فكانت عدد التوصيات والاجتماعات يعني وضحت لنا كل احتياجات خدمات الرعاية الكلوية بعد الله سبحانه وتعالى، ثم إخلاصهم وإحسانهم. فشكرا لكم من الأعماق، وأسأل الله أن يبارك بجهودكم وأعمالكم، وأن يوفق الزملاء العاملين حاليا في خدمات الرعاية الكلوية في الإدارة العامة لشؤون المراكز المتخصصة، لإدارة مراكز الكلى مع الدكتور عبد الجليل، قائد التخصص الدكتور ياسين. شكرا لكم من الأعماق، متفائلين بإذن الله أن سننتقل إلى مرحلة تتواكب مع معطيات المرحلة القادمة من تنظيم وتشغيل في الخدمات الصحية. رسالتي الأخيرة وهي طلب من الجميع، يعني سواء الحضور، المنظمين، الخبراء، المحاضرين، أتمنى أن نخرج بتوصيات من هذا الملتقى أن تكون متواكبة مع احتياجات ومعطيات المرحلة القادمة. نحن نمر الآن في مرحلة تحولية، أصبحت الرؤى واضحة جدا، أصبح دور الوزارة كمنظم للخدمات الصحية أوضح بكثير من السنوات الماضية. الآن نحن نستعد للأدوار القادمة، فأصبح يناط بوزارة الصحة الإشراف العام على الخدمات الصحية، تنظيم البوليسي والسياسات العامة لتقديم الخدمات الصحية، واللي اليوم نتكلم عن الرعاية الكلوية. فأتمنى في محور من محاور توصياتكم أن نركز على أدوار الوزارة القادمة وما هي توصياتكم كخبراء. لا أعتقد نقدر نفتي في الرعاية الكلوية بعدم وجودكم، فوجود مثل هذا الملتقى يعطينا توجه عام لخدمات الرعاية الكلوية. فأتمنى أن تكون التوصيات مواكبة للدور المستقبلي. هذا من جانب. الجانب الآخر وهو جانب مهم جدا، جانب الدور التشغيلي. الآن بعد موافقة المقام السامي وإنشاء شركة الصحة القابضة، الذراع التشغيلي لوزارة الصحة، أتمنى أن تكون توصياتكم اليوم مواكبة للاحتياجات والتطلعات من الجهة التشغيلية وهي شركة الصحة القابضة بتجمعاتها المرتبطة فيها. فيحتاج نعرف ما هو المسار المناسب لخدمات الرعاية الكلوية. هل نحن متواكبين مع نموذج الرعاية الصحية الجديد FS؟ نحتاج نعرف ما هي المحددات اللي تسمح لي أعرف هل هذا التجمع يسير في المكان أو في التوجه الصحيح أم لا. فنحتاج منكم جانب تشغيلي. ما هي التوصيات؟ لو أنت مكان مدير التجمع ماذا تفعل لضمان وصول خدمات الرعاية الكلوية في الشكل الصحيح بالجودة الصحيحة في الوقت الصحيح؟ فأتمنى أن تكون توصياتنا اليوم متواكبة جدا، لأنه بعد ما ينتهي هذا الملتقى ونسوي يعني مراجعة عامة على كل توصياتكم العلمية، لازم نحطها في قوالب عملية. فالقوالب العملية ستساعدونا عليها إذا كانت موجهة، هل هي للمنظم اللي هي وزارة الصحة التي ستعنى في تنظيم الخدمات في القطاع الخاص والقطاع الحكومي، والقطاع الخيري كخدمة صحية تقدم في الوطن. فنتمنى أن توصياتكم تكون متواكبة مع احتياجات وتطلعات الوزارة. أيضا نحتاج توصيات أخرى تساند وتساعد الزملاء اللي يعملون الآن على التشغيل في شركة الصحة القابضة في أذرعتها التشغيلية. أكثر من 21 تجمع صحي هم بحاجة الآن لمعرفة ما وصل إليه العلم فيما يخص الرعاية الكلوية، ما هي تجرباتكم، ما هي توصياتكم لضمان تقديم خدمات الرعاية الكلوية بالشكل الصحيح. لا ودي أطيل عليكم، ولكن أختم بتكرار شكري لكم جميعا. أتمنى أن يكون هذا الملتقى مفيد، يغذي الساحة بالمعلومات العلمية، وبأدوارنا بإذن الله ندرجها على الأمور التشغيلية، ندرجها نضمن تنفيذها بإذن الله بذراعنا التشغيلي لهذا الملف الإدارة عامة للمراكز المتخصصة، واللي باسمكم جميعا أشكرهم بقيادة أخي الدكتور عبد الله السهيمي. شكرا لكم من الأعماق، وأتمنى لكم مؤتمر مفيد بإذن الله يخرج بالعديد من الفوائد لكم وللمستفيدين من خدمات الرعاية الكلوية. والسلام عليكم ورحمة الله وبركاته.
الشكر أيضا موصول للدكتور فيصل الدهمشي على هذه الكلمة. ومن منطلق من لا يشكر الناس لا يشكر الله، حديث الرسول اللهم صل وسلم عليه، يتقدم الدكتور رائد بن فهد المطيري نائب المدير العام لشؤون المراكز المتخصصة بوزارة الصحة لتكريم شركاء النجاح في هذا المؤتمر.
سعادة راعي الحفل، سعادة رئيس المؤتمر للمؤتمر السعودي لأمراض الكلى، وسعادة رئيس اللجنة العلمية، السادة الحضور، الأطباء المشاركين والمحاضرين من غير الأطباء، السلام عليكم ورحمة الله وبركاته. باسم الإدارة العامة لشؤون المراكز المتخصصة نرحب بكم في المؤتمر السعودي لأمراض الكلى. يسعدنا ويشرفنا وبكل فخر أن نكرم نخبة من المتميزين في خدمات الرعاية الكلوية في وزارة الصحة، والتي تسعى وبكل جهد وتولي كل الاهتمام لخدمة فئة غالية على قلوبنا، مرضى القصور الكلوي المزمن. نفخر بالتميز الذي تحققه الوزارة في مجال خدمات الرعاية الكلوية، سواء في خدمات الغسيل الدموي أو البروتيوني أو المنزلي. لن أطيل عليكم أكثر، فالإنجازات التي حققت في هذا المجال والتي تم تقديم موجز عنها قبل قليل هي التي تتحدث، وهي أبلغ وأصدق من كل الكلام. والآن يشرفنا بتكريم المتميزين راعي الحفل دكتور طريف بن يوسف الأعمى، وينوب عنه سعادة الوكيل المساعد لخدمات المستشفيات الدكتور فيصل بن سالم الدهمشي، وسعادة مدير عام الإدارة العامة لشؤون المراكز المتخصصة ورئيس المؤتمر الدكتور عبد الله بن محمد السهيمي، فليتكرموا بالتقدم لتكريم المتميزين. يتقدم مدير إدارة الكلى الدكتور عبد الجليل الهندي. شاكرين لكم دعمكم الدائم لكل الممارسين الصحيين ولجميع المراكز ووحدات الكلى. نبدأ بتكريم من كان لهم بصمة جميلة وأثر ملموس في خدمات الرعاية الكلوية على مستوى وزارة الصحة. نبدأ بسعادة الدكتور وقائد تخصص كلى السابق سعادة الدكتور محمد بن عبد المعتاني المغربي. سعادة الدكتور خالد بن إبراهيم المعثم. سعادة الدكتور يوسف بن صالح الحيدان. الآن نبدأ بتكريم المراكز المتميزة في خدمات الرعاية الكلوية. مدينة الملك سعود الطبية، مركز الملك فهد الخيري لأمراض الكلى. مركز الملك سلمان لأمراض الكلى. مركز الكلى بمستشفى الملك فهد التخصصي ببريدة. قسم أمراض الكلى والغسيل الدموي بمستشفى الملك فهد التخصصي بالدمام. إدارة التطوير والتدريب المهني والمحاكاة بتجمع الرياض الصحي الثاني. مديرية الشؤون الصحية بمحافظة حفر الباطن. مركز النور لأمراض الكلى بمستشفى النور التخصصي بمكة المكرمة. مركز الملك عبد العزيز لأمراض الكلى بالمدينة المنورة. مديرية الشؤون الصحية بمحافظة الطائف. التجمع الصحي بمكة، خدمات الكلى بمنطقة عسير، مديرية الشؤون الصحية بمنطقة جازان، تكريم اللجنة العلمية للمؤتمر السعودي لأمراض الكلى، رئيس اللجنة العلمية لمؤتمر الكلى الدكتور ياسين بن محمود الحمد. الدكتور محمد بن ناصر العومي، الدكتور عبد الكريم بن مهنا العنزي، الدكتور عبد الجليل بن محمد الهندي، الدكتورة وافدة عقيل الشريف، الأستاذة موضي بنت مطلق السبيعي، الآن مع تكريم الشركات الراعية للمؤتمر. الراعي الرئيسي شركة فرزينيوس، شركة باكستر، شركة إمجن، شركة الرضوان، شركة سيباكو، شركة فيفور فارما، شركة باير، شركة ميدي سيرف، الآن مع الدرع يقدم راعي الحفل سعادة الدكتور فيصل بن سالم الدهمشي. في الختام لابد من الإشارة إلى الدور الصراحة الهام والذي ذكره الدكتور فيصل قبل قليل لجميع الكوادر الطبية العاملة في مراكز وحدات الغسيل الكلوي، والذين يعملون دائما يا دكتور بروح الفريق الواحد كل في اختصاصه للوصول للهدف المنشود والرؤية المتماثلة في تحسين جودة الخدمة العلاجية. أقول لهم شكرا من الأعماق، وأقول لك شكرا لك وللدكتور عبد الله على دعمكم دائما المستمر لهذه المراكز والوحدات. الآن صورة تذكارية على الستيج.
بعد الصورة التذكارية ندعو راعي الحفل لافتتاح المعرض المصاحب، ولمن يرغب من الحضور بحضور المعرض المصاحب للمؤتمر نرجو منها التكرم بالنزول من السلم الأيسر. وتقبلوا تحيات محدثكم ناصر الحربي، والسلام عليكم ورحمة الله وبركاته.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. We will start our afternoon session for today. And our first speaker is Professor Rotheld G. Weber. She is a professor of the Department of Human Genetics in Hanover Medical School. She is leading a research group performing genome with screening analysis on a number of different phenotypes. Her work has a strong focus on data interpretation and its translation to enable clinical diagnosis and to guide a decision in patient care. She is an author of over 50 experimental publications in a range of top international peer-reviewed journals. Professor Rotheld will talk about understanding congenital anomaly of the kidney and urinary tract, what we can learn from genetics and disease model. Professor Rotheld, the floor is yours.
Honorable colleagues, thank you very much for the kind introduction. It's a great honor for me to speak at the Saudi Nephrology Conference. First of all, please allow me to introduce you to the Hanover Medical School CACUT Task Force. We are composed of the Hafner Group in Pediatric Nephrology, the Kispert Group working on murine developmental biology, Jan-Hinrich Bresen, our nephropathologist, and my group in the Human Genetics Department. In my talk, I will present some of our own studies, but also interesting data from the literature. Next slide, please. As you well know, CACUT comprise various structural malformations that result from defects in the morphogenesis of the kidneys and or the urinary tract, such as kidney agenesis or duplication, kidney hypoplasia and dysplasia with or without cysts, anomalies of the ureter or the urethra. Please go back. Thank you. Taken together, the prevalence of all CACUT types is 3 to 9 in 1,000 live births. CACUT account for 15 to 30% of all prenatally diagnosed malformations. And CACUT are responsible for around 50% of cases with chronic kidney disease in children. These numbers make CACUT epidemiologically and clinically highly relevant. Next slide, please. Next slide, please. Most CACUT cases are sporadic. Around 15% are familiar. Inheritance is mostly dominant, but recessive inheritance has also been described. CACUT can be isolated or associated with more than 500 syndromes. Today, around 60 genes are known to cause human CACUT if mutated. CACUT-associated genes code for transcription factors, cytoplasmic signaling proteins, membrane-associated proteins, secreted proteins, and others. Next slide, please. Here are examples for disease gene identification strategies in human CACUT. CHD1L and TBX6 were identified because they are located within microdeleted or microduplicated regions. Next slide, please. Microdeletions and microduplications are also called copy number variants. meaning that less or more than 2 copy numbers exist of a gene or a genomic region. 10 to 15% of cocoon patients carry copy number variants. Certain chromosomal regions are frequently affected by deletions in yellow and duplications in blue, such as 1q21, 4p, 16p, 17q12, and 22q11. Next slide, please. CHD1L and TBX6 became cocoon candidate genes because they are located within deletion duplication regions frequently affected in human cocoon. CHD1L in 1q21.1 and TBX6 in 16p11.2. In the upper left corner, you can see an array CG8 profile of chromosome 1, showing a balanced state throughout, except in the center below the centromere, where it is duplicated. This genomic region harbors 8 genes, of which CHD1L is one. You can see that in the center, upper panel in the center. In the lower left, you can see that the red bars designate the deleted area in chromosomal band 16p11.2. And TBX6 is one of the genes located within this deletion. Next slide, please. A strategy that can be used in countries with large families, such as in the Middle East, is whole exome sequencing followed by a linkage-based strategy. This is how DSTYK and TBX18 were identified. Next slide, please. Analyzing this large family with uretero-pelvic junction obstruction and hydronephrosis led to the identification of DSTYK as a new cocoon-associated gene. 7 affected family members, designated by black symbols, were found to carry a heterozygous canonical splice site variant in the DSTYK gene, which is presumed to be pathogenic, designated by the small red circle. However, as is typical in cocoon, 2 unaffected family members, designated by white symbols, were also carriers, designated by the small red circle. So here we have incomplete penetrance. Incomplete penetrance is frequently observed in cocoon. Next slide, please. Analyzing 3 individuals of a different large family with uretero-pelvic junction obstruction and hydronephrosis led to the identification of TBX18 as a new cocoon-associated gene. The detected heterozygous TBX18 frameshift mutation was fully penetrant. That is, all 7 affected family members, designated by black symbols, that could be genetically tested carried the variant, but no unaffected family members designated by white symbols. Next slide, please. To understand how hydronephrosis and hydroureter develop, let me remind you of the different ureteral layers. The murine ureter is composed of an epithelial layer of urothelial cells in blue, followed by stromal cells in red, and a mesenchymal layer of smooth muscle cells in green. Hydronephrosis and hydroureter can result from aberrant development of the mesenchymal layer, such that mesenchymal cells do not differentiate to smooth muscle cells. Next slide, please. This is the case in a mouse model of TBX18 deficiency. The TBX18 deficient ureter contains a thin layer of mesenchymal cells. Next slide, please. That differentiate into smooth muscle cells, resulting in hydronephrosis and hydroureter. A ureter without a smooth muscle layer lacks elasticity and peristaltic abilities and has very little function. Next slide, please. Taken together, ureteropelvic junction obstruction and hydronephrosis were detected in the family carrying a heterozygous TBX18 frameshift variant and the TBX18 knockout mouse. The severe ureteral phenotype in the TBX18 knockout mice and the fact that the family carried a TBX18 loss of function variant may explain the complete penetrance in the family. Next slide, please. Another disease gene identification strategy is whole exome sequencing and trio-based de novo analysis. This is how we identified TBC1D1 and LIFR as new CACUT-associated genes. Next slide, please. The trio-based de novo strategy is a promising approach in sporadic CACUT patients. Those are single patients in a family with healthy parents. In this strategy, whole exome sequencing is done on paternal and maternal DNA in addition to patient DNA. Next, paternal and maternal variants are subtracted from patient variants. Please go back. Please go back. Yeah, thank you. That way, only unique patient variants, that is, de novo variants, remain. Prerequisites are blood samples from both parents in addition to blood sample of the patient. This is how we identified the first de novo truncating variant in the LIFR gene. Next slide, please. LIF signaling is implicated in nephrogenesis induction. LIFR encodes a transmembrane receptor mediating LIF signals through JAK-STAT-regulated gene expression. To date, a total of 3 loss-of-function variants in LIFR were detected in patients with multicystic dysplastic kidneys, kidney agenesis, or hydronephrosis. Next slide, please. In mice, loss of LIFR, outlined in red, resulted in hydronephrosis and ureteral obstruction due to thickening of the urothelial layer. In addition, in LIFR knockout mice, we observed an increased cell shedding into the lumen of the ureter. The desquamated cells expressed uroplakins, identifying them as urothelial superficial cells. Next slide, please. Our data suggests that hydronephrosis and hydroureter can also be linked to the aberrant development of the second ureteral layer, the urothelium. From E16.5 in urine development, the urothelium is composed of 3 layers, the intermediate cells giving rise to basal and superficial cells. Next slide, please. Upon further characterization of the ureters of LIFR deficient mice by immunofluorescence, expression microarrays, and RNA in situ hybridization, We mainly found a pathology of the urothelium. The results are summarized in the lower right scheme. We detected an increased differentiation of intermediate to basal and superficial cells, increased urothelial cell proliferation, signs of inflammation, and increased superficial cell shedding. Collectively, our data provide evidence that a genetically induced inflammation leads to increased cell proliferation, superficial cell shedding, a ruffled surface ill-protected from urinary toxins leading to clogging, and physical obstruction causing hydronephrosis. Next slide, please. The urinary tract anomalies detected in LIF-R deficient mice, outlined in red, were recapitulated in a patient with a LIF-R haploinsufficiency, outlined in blue, who had a thickened, ruffled urothelium compared to a control, and increased superficial cell desquamation compared to a control in the urine. Our findings indicate conserved LIF-R-dependent urinary tract changes in the murine and human context. Next slide, please. Our data implicates insulin signaling in CACUT. In 2016, we first described mutations in TBC1D1, regulating insulin-stimulated translocation of the GLUT4 receptor to the cell membrane in CACUT patients using the trio-based de novo strategy. To date, 3 loss-of-function variants in TBC1D1 were detected in patients with kidney dysplasia or agenesis. Thus, evidence for a role of TBC1D1 variants in CACUT is increasing. Next slide, please. To identify please go back one. To identify recessive disease genes, whole exome sequencing and screening for biallelic variants, the so-called two-hit strategy, is often successful. This is how ITGA8 and ROBO1 were identified. Next slide, please. ITGA8 encoding an integrin and ROBO1 encoding a transmembrane receptor and slit-robo signaling are recessive CACUT genes. Variants are either homozygous, that is, the same variant is found on both alleles in consanguineous families, or compound heterozygous, that is, a different variant is found on each allele in non-consanguineous families. Next slide, please. In family 1, carrying a homozygous ITGA8 variant, and in the patients carrying biallelic ROBO1 variants, variable expressivity is observed. Some fetuses or patients are affected by bilateral renal agenesis, some only by unilateral renal agenesis, some only by a reduced kidney size. Variable expressivity is frequently observed in human, but also in murine CACUT. Next slide, please. We identified GDF6 by prioritizing known human syndromal genes in whole exome sequencing data sets. Next slide, please. By prioritizing variants in genes associated with syndromic CACUT, we identified a variant in GDF6 known to cause Klippel-Feil syndrome in a patient with CACUT and features of Klippel-Feil syndrome. Next slide, please. Next slide, please. Investigating a larger CACUT cohort, we found heterozygous GDF6 variants in 5% of CACUT patients who also had skeletal, auricular, and ocular anomalies. Pronephros development was impaired in xenopus with downregulated GDF6 expression compared to morpholino control. This phenotype could be rescued. Next slide, please. Our data indicates a role for GDF6 in xenopus kidney development and human Kakut pathogenesis, and add Kakut to the anomaly spectrum of clinical Klippel-Feil syndrome type 1 caused by GDF6 mutations. Next slide, please. The GDF6 gene encodes a ligand belonging to the TGF-beta family that signals via BMP receptors. GDF6 expression during murine kidney development is found in epithelial cells of the ureteric tree, including the ureteric tips, structures involved in ureteric budding and branching. The Kakut phenotypes observed in GDF6 variant carriers, that is, kidney agenesis and kidney hypodysplasia, are potentially caused by defects in ureteric budding and branching of the ureteric tree. Thus, the expression pattern of GDF6 may determine the spectrum of Kakut phenotypes in GDF6 variant carriers. Next slide, please. We found DUCT1 to be mutated in human Kakut by prioritizing known murine Kakut-associated genes in data sets from whole exome sequencing. Next slide, please. Whole exome sequencing in a patient with Kakut and caudal regression syndrome, including anorectal agenesis, did not yield any variants in human Kakut-associated genes. Therefore, we prioritized murine Kakut-associated genes and identified a very rare missense variant in DUCT1. Next slide, please. When comparing the published phenotype of DUCT1 knockout mice and that of our patient, we noticed that there was quite an overlap with respect to Kakut, anorectal malformation, and caudal regression. Therefore, the identified DUCT1 missense variant seemed to explain the phenotype of our patient, and DUCT1 seemed like an interesting new Kakut-associated gene in humans. Next slide, please. Next slide, please. Okay, sorry, please go back. Human DUCT1 inhibits Wnt signaling by binding disheveled, presumably via its central and C-terminal region. Interestingly, all missense variants that we detected in 8 of a total of 209 Kakut patients were located within the putative disheveled interaction region. Next slide, please. While very rare non-silent DUCT1 variants were detected in 3.8% of all Kakut patients we analyzed, and 9.4% of Kakut patients with specific syndromic features, the frequency was significantly lower in controls. We conclude that very rare DUCT1 variants cause Kakut with features of Townes-Brooks syndrome 2, including anomalies of the brain, skeleton, particularly the spine, genital and digestive tract. Next slide, please.
Professor Whopper, we have 3 minutes left.
Okay, thank you. The DUCT1 gene encodes a cytoplasmic mediator of Wnt signaling. DUCT1 expression during murine kidney development is confined to the mesenchyme of the ureter, kidney capsule, cortical and medullary stroma. The Kakut phenotypes observed in DUCT1 deficient mice and DUCT1 variant carriers, that is kidney fusion and multicystic dysplastic kidney, are potentially linked to DUCT1 expression in the kidney capsule and the cortical and medullary stroma. Next slide, please. Finally, a translational aspect. A recent review has compiled the genetic yield in 2,250 unselected cocoon patients from 12 different studies. On average, a genetic etiology was detected in 16% of cocoon patients. Next slide, please. We have put together a selected cohort of cocoon patients diagnosed before the age of 3 years from Hanover, Germany and Oslo, Norway. In this cohort, the diagnostic yield was 25%. This yield is quite a bit higher than the mean yield in unselected cocoon cohorts of 16%. Next slide, please. Interestingly and not unexpectedly, cocoon patients with severe manifestations requiring kidney replacement therapy before the age of 3 years were significantly more likely to carry likely pathogenic variants than patients not requiring dialysis or transplantation. Thus, genetic testing should be considered especially in cocoon patients requiring kidney replacement therapy. Next slide, please. It is also interesting and not unexpected that cocoon patients diagnosed before the age of 3 years that also had extrarenal anomalies were significantly more likely to carry likely pathogenic variants than patients without extrarenal anomalies. Therefore, genetic testing should be considered especially in cocoon patients with extrarenal anomalies. Next slide, please. As the extrarenal anomalies associated with some of the genes we found mutated are known, cocoon patients may benefit from genetic testing in infancy regarding the early detection and management of these anomalies. Next slide, please. Here are my take-home messages. Different strategies exist to identify new cocoon-associated genes that I've spoken about. Incomplete penetrance and variable expressivity are frequently observed in cocoon. Murine in vitro and in vivo models help us interpret and understand genetic patient data and pathomechanisms involved in cocoon. Different ureter layers, that is the epithelial and the mesenchymal layer, are linked to hydronephrosis formation and other forms of cocoon. The spatial and temporal expression pattern of cocoon-associated genes during murine kidney development may explain the cocoon phenotype of knockout mice and variant carriers. While the mean diagnostic yield of genetic testing in unselected cocoon cohorts is 16%, it is higher in specific cocoon cohorts. In cocoon patients diagnosed before the age of 3 years, it is 25%. In cocoon patients diagnosed before age 3 with extrarenal anomalies, it is 41%. In cocoon patients requiring kidney replacement therapy before the age of 3 years, it is 43%. Next slide, please. Here are my acknowledgements. I'd like to thank colleagues from Hanover Medical School, national and international collaborators, sponsors, and thank you very much for your attention.
Thank you very much, Professor Wipper. Now it is the time for the questions, and if you allow me, I have 2 questions. The first one is, when we should do the gene study, is there any certain indication for the congenital anomaly of the kidney and urinary tract? What type of gene study we should do? And my second question, I am wondering why you think it is important to do the gene study where we don't have a diagnostic challenge for urinary tract. Usually we diagnose them if we do the proper imaging study, and most of the patients, they respond to surgical or medical therapy. Do you think it will be important, for example, to differentiate those who need surgical versus conservative medical therapy?
Those are actually 2 excellent questions. Thank you very much. The first question was which patients to test, right? Which patients should we test genetically?
Yes.
And the answer is the more severely a patient is affected, the more likely it is that there's a genetic basis for this. So if the patient has bilateral Cucut, if the patient requires renal replacement therapy in childhood or adolescence, the likelihood is higher that we will find a genetic basis. If the patient has extrarenal anomalies, the likelihood is higher that we will find a genetic basis. The more severely the patient is affected, basically, if a patient is severely affected with respect to the kidney and with respect to extrarenal anomalies, then I would advise genetic testing. And if a patient needs renal replacement therapy because of Cucut, then I would advise genetic testing. The second question was, what's the relevance of genetic testing? First of all, we're doing this research. We're studying the genetic basis of Cucut to understand how Cucut develops, to understand how the kidney develops, and to develop and to understand kidney maldevelopment. But secondly, if the patient has a genetic diagnosis, we understand what sort of a disease he has. And this disease may be associated with additional features. And if we identify the genetic disorder in the patient, then we can test then we can test the patient early for extrarenal features, to detect the extrarenal features early and to manage them early or even predictively.
Thank you very much. I think for the sake of time, we will stop here. Thank you, Professor Weber, for the excellent talk and informative talk today.
Thank you very much for inviting me to this very interesting meeting. Thank you.
Thank you. Next speaker I will be Dr. So now it's my pleasure to introduce our next speaker, Professor Detlef Buchenauer is a professor of pediatric nephrology at University College London and honor consultant at Great Ormond Street Hospital in UK. He has a special interest in inherited kidney diseases and tubulopathy and renal physiology. And he is going to give us a speech about the tubulopathies living with an abnormal electrolyte. Dr. Detlef, the floor is yours.
Hello, everybody. And well, here it's still morning. For you, I think it's afternoon. Yeah, if we can have the first slide and then the next one, please. Go on, next. So when we think about what are the functions of the kidney, next, first one obviously is elimination of waste products. That's pretty much synonymous with kidney function. If we talk about on the ward, what's the kidney function, we mean creatinine and we mean GFR. But there are more important functions. Next. There's the homeostasis, which is what the tubules do and what I will talk about in this one. And then, of course, next, the endocrine functions, which like making renin, erythropoietin, and so on. Next. Next. How synonymous elimination of waste product, filtration of waste product is with kidney function, I think is pretty obvious here from this slide, which is from Kidney Research UK. And this is a slide that's for patients who want to Google how the kidney works. And you can see how dirty blood is going into the kidney, and then it goes through these super filters that clean the blood so that all the waste products leave down here in the ureter, and the beautiful clean blue blood goes back into the body. Next. So that's all about filtration, but there is nothing in that slide, in the previous slide, about the tubules. And for those people like myself who are obsessed with the tubule, the glomerulus is really only the little appendage to this entire structure, which we call the nephron, and from which we have about 1 million in our kidneys. Next. Next. Next.
I think we lost you, Dr. Detlef.
Yeah, sorry. If you can go back one slide. Okay, we're going forward. We are now off track. So just the next one, please, then. Now we're back. Okay, so for the tubular people, this glomeruli, these super filters, are actually super stupid, because what they do is they throw out enormous quantities of bath water, and it literally is bath water. It's the fluid, the extracellular fluid that bathes all our cells. And at 100 mL per minute, that's 6 liters per hour. That's roughly 150 liters of bath water that's just thrown out by these super filters. And in this bath water are a lot of precious babies. There is the equivalent of the more than 1 kilogram of salt in there, hundreds of grams of amino acids, sugars, and it's all thrown out there by these super filters. And who needs to clean it up? Well, it's our tubules. So without our tubules, we would pee and thus would have to drink more than 150 liters per day. We would have to eat more than 1 kilogram of salt to keep up with our urinary losses, plus all the other stuff that's thrown out there. So next slide, please. And if you think about that, it's really a very strange way for our kidneys to clean our blood to get rid of waste products. If you think about how you get rid of waste products in your house, well, you put it in the bin. And at the end of the collection period, you put the bins out, and then the rubbish is gone. If you were a kidney, what you would be doing is you would be taking a big hose and flush everything out of the house, everything that fits through the door and the windows. That would be the pore size of the glomerular filter, so the big wardrobe, and the sofa stays behind. But everything else, your books, your crockery, your cutlery, it's all flushed out into the front lawn. And then you employ an army of highly specialized robots. Those would be your tubular transporters. And one of these robots picks up all the knives and brings them back in, puts them in the right place, in the right number in the kitchen. And another one picks up the plates, puts them all back into the house, in the right place, in the right number, and so on. And at the end of this incredibly laborious process, there will be the empty yogurt cup, the banana peel, and the old newspaper still lying out on the front lawn, but everything else has been brought back into the house. It's a really laborious, highly complicated way of getting rid of waste product. And it certainly doesn't sound like it was intelligently designed. Next slide. And this is your army of highly specialized robots. Don't worry, I'm not going to go into details about all these molecular players, but you have all these highly specialized transporters in there, the highly specialized robots. One of them picks up sodium phosphate, another one sodium glucose, another one sodium potassium chloride, and so on. So these are designed to bring back specific substances from the tubular lumen, from the filtrate, from the stuff that's all been thrown out by these filters back into the bloodstream. And you can imagine that if one of these transporters is broken, you typically get a very specific phenotype. If the robot that brings in the knives is broken, you will have lots of knives in your front lawn, which would be the urine, and you would have very few knives left in your house. That would be the blood. So for instance, if the transporter for phosphate is broken, you will have more phosphate in the urine and less phosphate in the blood. Next slide, please. And this would be me in my favorite clinic, the tubular clinic, where we try to deduce from the urine and plasma biochemistries and the clinical examination of the patient which of these transporters is dysfunctional. Next slide. And when we have these tubular clinic, well, it's the tubules that are that tubule dysfunction, homeostasis is off, and we get lots of abnormal electrolytes. So on a Tuesday afternoon, the afternoon after the clinic, my telephone is usually quite busy with the lab calling me to tell me about some highly abnormal values. The lab has this level, let's say for potassium, if it's less than 3, it's called a panic value, and the lab needs to inform the clinician straight away so that I can do whatever needs to be done in order to save the patient. And when you do a tubular clinic, you can imagine there are a lot of panic values that are being called in. Next slide. And the answer, of course, is that's because of this strange principle of filtration and reabsorption. And I told you before, it certainly doesn't sound like it was intelligently designed. And no, it was not intelligently designed. It is evolution that created this system. And life evolved in the ocean. And in that ocean, you had a certain concentration of electrolytes. And so the function of our excitable cells, the neurons, the muscles, very much depends on having the right concentration of electrolytes on hand. And of course, filtration of waste product also made perfect sense in the ocean. Who cares if you're losing a bit of salt and water in the process? You're living right in it. You just open your mouth, your gills, or whatever you have, and comes straight back in. But when life moved on to land, that really was only possible because we evolved ever more powerful tubules that maintained this ancient ocean environment within us and minimized the losses of all the filtrate that is otherwise going out. And if this tubular function is impaired, like in our patients with tubulopathies, then serious abnormalities in this internal environment, in this internal milieu can happen. Next slide. So this is how normal values are typically defined. You have a normal distribution, a Gaussian curve, and usually what fits in, let's say, 2 standard deviations or so is what's considered normal, and what's outside these 2 standard deviations, so outside the 95%, that would be considered abnormal. Next slide. And if you have patients with tubular disorders, and the tubules are responsible for maintaining these normal ranges, then you very often have electrolyte values that are very much outside, perhaps even more than 3 standard deviations out of the normal range. And that would be those panic values that we then get called about. Next slide. And I have my own personal tubular wall of fame, where I sort of get the most extreme abnormalities that I've encountered so far. So for sodium, the lowest I have seen is 99, although admittedly that was not in a tubular patient, that was in a patient with nephrotic syndrome, congenital nephrotic syndrome. The highest, 201. This was in a patient with nephrogenic diabetes insipidus. Potassium, the lowest I've seen is 1.0 in a little baby with Bartter type 3, and the highest 12.4 in a newborn baby with pseudohypoaldosteronism type 1. Chloride as low as 56, as high as 184, and pH as low as 6.7 in distal RTA, and as high as 7.9 in a patient with Bartter 4. So you can see that there's a lot of panic values that come along when you do a tubular clinic. Next slide. And when you get so many panic values, you start to get a little bit nonchalant about it. You get a bit jaded, and you really ask yourself, come on, this patient with a potassium of 1.8 walked into your clinic, has been functioning completely normal. Is this really a panic value? Do I really need to panic about that? Is this an emergency? Or could it be that those patients who are chronically living in this low range have actually adapted and function quite well? In general, actually, my teaching to our junior doctors is the more extreme the electrolyte abnormality, the more they should relax. If you have a sodium of 99 or sodium of 201, the only reason why that patient is still alive is because this has developed chronically. This is not something acute, because if it was acute, the patient would be dead. So this is something that's a long time, and the last you've been immediately and try to drastically change that, because if it's chronically developing, if at all, you want to chronically correct it. And the other reason why I get so jaded about these abnormalities is that it's often difficult, if not impossible, to actually correct them. When you have a tubular wasting disorder, that's, for me, the analogy I use often is it's like trying to fill a bucket with a slit on the side. And the more you pour in, the more supplements you pour in, the more is just coming out in the urine. And the main effect that you're giving is that you give the patient very expensive urine, because all these supplements that you give just come out in the urine, and you hardly do anything in order to correct the electrolytes. And of course, then I need to ask myself, am I just getting old and jaded and complacent, or is this a real problem? And there was a recent case that made me reflect on that quite a bit, and I would like to share this case with you. So next slide. Next slide. Yeah. So this was a 15-year-old boy who was previously fit and well, and who came to the emergency department in the UK. It's called A&E, Accidents and Emergency, with cervical lymphadenopathy. And as part of his examination there, he also had blood tests. And they surprisingly showed a potassium of 2.6 and a magnesium of 0.55. And those were panic values in the hospital. So he was immediately admitted. He got ECG pads on his chest. He was given an intravenous infusion of potassium. And after several of these potassium corrections, I mean, as doctors, we love to correct things, right? After several of these potassium corrections, his potassium level eventually became normal, and then he was discharged on potassium supplements. But when they subsequently do an outpatient repeat blood test, he had again hypokalemia and hypomagnesemia, despite all the supplements that he was given. Next slide. And so over the next few weeks, he had repeated visits to the emergency room, quite symptomatic, complaining of chest pain, of cramps, of fatigue. Fatigue was so severe he couldn't do any exercise anymore. And that, of course, prompted blood tests. And those blood tests showed hypokalemia and hypomagnesemia. And the doctors obviously responded to that by increasing the supplements. And then they did another blood test and it was still low, and they increased it even more. And eventually this boy was supposedly taking more than 50 tablets per day. And his parents were insisting that, yes, he takes those. He's really taking them. But despite all this, his symptoms are not improving. If anything, they're actually getting worse. He is now so fatigued that he cannot attend school anymore. And all he does is sit in his room and play on his computer. And he even has a dramatic fainting episode right in front of his parents at home, which of course worried the parents tremendously. Next slide. So at this point, I had only been engaged indirectly by giving telephone advice, and eventually then he came to our clinic, and I was actually quite looking forward to seeing him because I wanted to see this severely symptomatic boy. And I was very pleasantly surprised, actually, because when he came into the clinic, he is this bright, fully engaged boy, really listening, could talk tubular physiology to him. He was understanding. He had his computer with him where he had taken notes, and when his mom was giving the history, he was correcting her. And so he looked really like a normal boy, normal 15-year-old boy, had a normal examination, had a blood pressure that normal, low normal perhaps. Next slide. And he had these blood tests. And I think if you have dealt with tubulopathies before, you will recognize the pattern immediately: the hypokalemic, hypochloremic, metabolic alkalosis with low magnesium, hypocalciuria, classic. Next slide. Next slide again. It's the classic constellation, obviously, for Gittel. They are sometimes indistinguishable, but in his case here, it was indeed Gittelman syndrome. And just a little bit more about these biochemistries as an aside, you can see that Gittelman syndrome is a salt wasting disorder, right? It's a sodium chloride co-transporter in the distal convolute that's broken. So intuitively, one would expect that the fractional excretion of salt is increased. But it's not. Look at his fractional excretion of salt. It's 0.1%. And that is actually quite typical for these salt wasting disorders. Salt is extremely important for the kidneys to maintain volume homeostasis. If you're hypovolemic, the kidneys retain salt. If you're hypervolemic, the kidneys excrete salt. And if you were constantly losing more salt than is coming in, you would die of hypovolemia very quickly. And this is why there are all these compensatory pathways that can make up if one of these pathways, like in Gittelman syndrome, the SLC12A3, if that's broken, well, then you upregulate aldosterone and you will have enhanced salt reabsorption downstream in the collecting duct through the epithelial sodium channel. And that's where it is actually in exchange for potassium and protons, which is why you get the hypokalemic alkalosis. But in steady state, whether you have a salt wasting disorder or normal tubules, your fractional excretion of sodium reflects what's coming in. Okay, and the first thing that you can tell then, if it was 0.1%, he was clearly not taking his salt supplements. If he was taking his salt supplements, what's coming in is equal to what's coming out, then you would expect his fractional excretion of sodium to be higher. So despite the assurances of his parents that he was taking his 50 tablets a day, he clearly was not taking the salt supplement. But you can also see that the fractional chloride excretion is actually a much better tool to discover a salt wasting tubulopathy. Because whether you excrete sodium or whether you excrete potassium and protons, all needs to be accompanied by an anion. So if you have this upregulation in the collecting duct where you're now reabsorbing sodium in exchange for potassium and protons, you're still excreting chloride. And your fractional excretion is 1%. And we typically say if it's higher than 0.5%, that's consistent with salt losses. You can also see the high fractional excretion of magnesium consistent with renal magnesium wasting. Okay, next slide. Okay, after this little excursion into the physiology of tubulopathies, back to our symptomatic patient with Gitelman syndrome, severely symptomatic. And that is a real problem when you take care of these patients. There have been surveys made in Gitelman syndrome that really show that the quality of life in these patients can be quite severely affected. They can have really severe symptoms with regards to cramps and fatigue, lack of stamina, and so on. But there is no correlation between the severity of the symptoms and the severity of the electrolyte abnormalities. There are patients who have quite marked electrolyte abnormalities who are incidentally discovered at the age of 50 when they have a routine blood test for some other reason and had a completely normal life until then. And then there are patients who are diagnosed in childhood and have severe symptoms, but have much milder electrolyte abnormalities. So this is something that was also discussed in this Gitelman KDU consensus paper, so you can read more about it if you want to. But the key thing is there is no correlation between the severity of the symptoms and the severity of the electrolyte abnormalities. Next slide. And the problem, of course, here is, or that we had with this boy, I think, is that if we get informed of the abnormal blood value, the potassium of 2.6, we start or we increase the supplements, we do something, we act, we are doctors, we rescue patients. And then we repeat the blood test and want to make sure that our action actually has worked. And then in these tubulopathies, unfortunately, we see that the potassium is still low and the magnesium is still low. So we increase the supplements and we retest and we increase and we retest, and we get into this vicious circle where we end up with these ever increasing supplements so that we give something like more than 50 tablets a day, as happened in this boy. Next slide.
We have 5 more minutes.
But the real question, I think that we need to ask ourselves is, do we really treat the patient with this, or do we treat just a number? Next slide. Yeah. So when I saw this boy, he was fully functional. His biochemistries actually were remarkably good for somebody with Gitelman syndrome. But the most important thing is, and that I discussed with him and his family, is that he had Gitelman syndrome all his life. He has had abnormal electrolytes probably for many years. And he only became symptomatic when he knew of his diagnosis. Next slide. And this is, I think, really important, because I think these symptoms and the severity of the symptoms very much depend on the context in which they are experienced. Before he knew of his diagnosis, I'm sure he had cramps and fatigues at some point. I have cramps and fatigue. Everybody has cramps and fatigue at some point. But it's just that, cramps and fatigue. But once he had seen the panic in his doctors when they saw these electrolyte abnormalities, when they slapped these ECG pads on, when they put in the IV and they gave him a correction and another correction, and then ever escalating doses of supplements. And then he had gone out on the internet and he's read that these disorders can be associated with sudden cardiac death and so on. Now, when he has a cramp or when he's fatigued, then it's not just a cramp, it's the harbinger of imminent death. Oh my God, it's the next step is going to be that I die. Next slide. So for me, when I saw him, I thought the most important job I have is to actually provide reassurance, to tell him that this is not a lethal disease, that there are literally thousands of patients with Gittelman syndrome who have a pretty normal life, that the incidence of Gittelman syndrome based on what we see in our clinic is to be estimated around 1 in 40,000, probably the most common tubulopathy. But based on the gene abnormalities in the population, it's probably much higher. It's as high as perhaps 1 in 2,500, which means in London alone, there would be about 4,000 people with Gittelman syndrome. And many of them are undiagnosed and presumably live completely normal lives without any supplementation, without any interference from doctors. Next slide. I'm coming to the end. So again, I tried to provide reassurance, and I thought I can only provide reassurance if I also stop his supplements. It's very difficult to tell him, oh, don't worry, it's not a severe disorder, but you better still take your 50 tablets a day. So I said, actually, you can stop all that. But I encouraged him to take them if he had symptoms, if he had cramps, to take some magnesium, if he was fatigued, to take salt supplements. And I also sent him to the psychologist to help him with this anxiety. Next slide. And with that, actually, he's back in school. He still has symptoms, absolutely, but he is much better functional. He loves his high salt diet. Next slide. And his biochemistries are pretty much unchanged to what they were when he was on supposedly more than 50 tablets a day. Next slide. So I don't want to tell you that this boy is just crazy in his head. I'm sure his symptoms are real. Again, he has these cramps, he feels the fatigue, but because he was now worried that this would be his imminent death, this is why he got in such a state where he was becoming completely dysfunctional. So it really is how you perceive these symptoms. The context matters in that regard. As pediatricians, we are all familiar with that. We have these patients where you bring in for a blood test and they worry about it already like a day before, and they're screaming their head off if it's the worst pain they've ever experienced. But then you have a good play therapist who manages to distract the patient, and then he doesn't even feel it. So even though the actual stimulus is exactly the same, it's the context that matters. Next slide, and I think that's the end then. So in conclusion, treatment of these tubulopathies is challenging because when you have a tubular wasting disorders, it is like trying to fill a bucket with a big hole in it. And often they have these abnormalities that are at the very extreme end of the spectrum. But there is some large doses of supplementation where we briefly bring it back up, and now I'm lost again. Briefly bring it back up, and then it goes down again, and then we bring it back up with supplementation that goes down, that it actually may be more dangerous. So with that, I'm going to stop, and you have 1 more minute for questions. So sorry that it's taking a little longer.
Thank you very much, Dr. Tidlif. If there is, for your excellent talk, if there is any questions from the audience. Yeah, we have a question back there. The mic. Okay. Until the mic reach our questions, like I think it's. Don't you think it's kind of probably too much to not to do anything for a pediatrician?
Yeah. So thank you for that question. Because I was running out of time, I was cutting it short. Most of my patients also get supplements, so I'm not advocating here that we should just ignore this. I mean, I could say, well, just discharge them from your clinic. They're just fine. I'm not saying that. Most of my patients have regular blood tests. They are on some supplements. But I think we need to have some reasonable balance between how much we give them and how often we do their bloods. And especially, we need to accept that in the vast majority of these patients, we cannot achieve normal electrolytes. They just have these low values because they're losing it, and we can help them somehow with these supplements, but we're not going to make them normal. And I think we just need to accept that.
Thank you.
Good evening. In case of you have hypokalemia with other trouble electrolyte, what I know, you must treat the hypokalemia first before magnesium or other. What's your opinion, please?
First of all, again, how is the patient? Not treating a number, treating the patient. Is the patient well? Is there no symptoms at all? Then I think you certainly have time, and it doesn't matter what you're trying to address first, the magnesium or the potassium. If the patient has EKG abnormalities and is severely symptomatic, well, then probably, yeah, you would do the hypokalemia. But there are some people who argue that you need to correct the hypomagnesemia in order to stabilize the potassium, and that's because magnesium blocks the ROMK potassium channel. I personally am not convinced of that, but there are some people who argue about that. So, but on the other hand, if you have symptoms that are more related to the hypomagnesemia, like cramps, then probably you want to address the magnesium first. So again, I think it's treating the patient. It's not treating individual numbers.
Dr. Maghrabi?
Thank you for this nice lighting. And I want to change just in 30 seconds our experience in a post-renal transplant for the hypophosphatemia, for example. We get used as a common practice. Once we have phosphate less than 0.6, we give potassium supplement directly. We decide not to give at all any phosphate supplements unless the patient is symptomatic or have some cardiac changes. We end by 0. Over the last 2 years, we do have 0 patients with the phosphate supplementations. With all phosphate normalize over a few days, and they remain overthrough in the post-transplant period. This is number one. Number two, and I agree with you 100% with electrolytes, not to panic with this abnormal results in potassium, magnesium, phosphate. You mentioned a nice thing about sodium panic result. What is the situation in the sodium panic result? Thank you.
So first of all, with this phosphate supplement post-transplantation, I fully agree with you. I mean, these patients typically have highly upregulated FGF23 from the time when they had chronic kidney disease. Now you put a kidney in that can you respond to it, and the kidney will just waste phosphate. And you can give them lots of phosphate supplements. It's just going to come out in the urine. It's just going to make the urine more expensive. So, but once the FGF23 comes down and the homeostasis is achieved again, then the phosphate levels will normalize as well, just as you say. So we also do not give routine phosphate supplements to these patients. And with regards to the sodium, I think this is really a classic example of the treatment.
Thank you very much, and
looks like frozen.
Thank you very much, Dr. Detlef, for being with us today. And because of the time, we are going to move now to the next speaker.
Yeah, thank you. Bye-bye.
Our next speaker is Professor Jamila Abdulaziz Qari. She is one of our senior pediatric nephrologists. Prof. Jamila is a professor of pediatric and consultant pediatric nephrologist at King Abdulaziz University. She is also a director of the Pediatric Nephrology Center of Excellence, and she is the head of Pediatric Nephrology Division at King Abdulaziz University. She is one of our senior pediatric nephrologists we are proud of in Saudi Arabia. She has more than 150 publications in high prestigious journals. Prof. Jamila.
Assalamu alaikum wa rahmatullahi wa barakatuh. Bismillah ar-Rahman ar-Rahim. Thank you very much, Prof. Khalid, for the generous introduction. Initially, I would like to thank the organizing committee for inviting me, particularly Prof. Dr. Al-Karim Al-Anazi, and I will talk about the impact of new advances in genetics in pediatric nephrology in the Kingdom of Saudi Arabia. Right. Pediatric nephrology is a growing subspecialty in the Kingdom of Saudi Arabia, and pediatric nephrologists are challenged with wide spectrum of renal diseases. The majority of those renal diseases, they have an underlying genetic component etiology, and this is particularly true in the Kingdom of Saudi Arabia because of the high consanguinity rate. How renal diseases transmitted? It is transmitted mainly by monogenic defect, where one defect in one gene out of 20,000 genes in our human genome cause the disease. This is what happens in the steroid-resistant nephrotic syndrome, where pudicin mutation is the cause of the disease, and also those monogenetic, there could be genetic heterogeneity. That means defect in many genes can cause the same disease. For instance, in steroid-resistant nephrotic syndrome, 67 gene can cause the same steroid-resistant nephrotic syndrome. The other category is polygenic, which is where is the risk alleles, and this is mainly adulthood disease. With the emerging technique of exome capture and total genome and large-scale sequencing, there is increased ability to diagnose diseases genetically and to know about the prognosis and to decide about specific therapy according to the genetic of the child, which we call it precision medicine, such as using coenzyme Q10 in children with steroid-resistant nephrotic syndrome and ACDK4. When we look at the causes of chronic kidney disease in children and young adults, if we look at the data, if we look at the data of the Nephratic in 2008, they studied 9,000 children, and as you can see, CACUT is the main cause in 50% of the children, followed by steroid-resistant nephrotic syndrome in 15%, and chronic glomerulonephritis in around 14%. The monogenic cause was detected in at least 45, actually Prof. Weber said 60 monogenic genes were detected in CACUT cases, 67 in steroid-resistant nephrotic syndrome, 10 in glomerulonephritis, 100 in cystic disease. Sorry. It is very sensitive. So on the whole, more than 250 monogenic causes of childhood renal diseases had been identified. If we look at this study from Prof. Hildebrand group from Boston, they looked at children who is receiving transplantation, and they studied 104 children, and they done for them whole exome sequencing. They identified the underlying genetic cause in 1/3 of them, in 32% of them. This is a more clear picture. As you can see, 52% in the blue, 52% of the cases was caused by CACUT, and out of those 18%, they were identified to have monogenic cause of the CACUT. When we compared that with nephrotic syndrome, steroid-resistant, which is green here, 43% of them were identified, the gene underlying the cause was identified. If you look at the purple, it is nephrolithiasis. It is contributed only to 3% of the causes of chronic kidney disease, and the whole exome sequences identified the whole genes, the underlying genetic cause in those children. The same group, they looked at children with kidney hyperechogenicity, and also for children with more than 2 renal cysts, and they did for them whole exome sequencing. They identified the cause in 2/3 of those children, and as you can see, the commonest cause was nephrolithiasis, followed by renal tubulopathy. When we come to our kingdom, we are characterized similar to most of the countries in the Middle East, that we have high consanguinity rate. The consanguinity, as it was studied back in 95, 3 decades back, it is around 58%, and it is mainly, it is variable according to the province, with highest province in Northwest province. Around a decade later, another study came, and And they found that the consanguinity is the same of 56%, with more consanguinity in the rural areas compared to the urban areas. This is a study in 2014 where Warsi and his group, they tried to answer the question, is consanguinity is decreasing in Saudi Arabia? So what they have done, they interviewed 600 educated females, and they asked them about the consanguinity in their generation and in their parents' generation. And they found that the consanguinity in their parents' generation was around 30%, 29.7%, compared to their generation of 38%. So they concluded that the tradition of marrying within the family is preferred practice in Saudi Arabia, despite the awareness that certain genetic diseases occur at higher frequency with cousin marriages. A more recent study in 2019 from Riyadh, again, they tried to answer the question, is the prevalence of consanguinity marriage among participating educated adults is going to the lower side, and they found that it is 40%, and they found that neither the age or at the time of the marriage, neither the likelihood of consanguineous, neither the level of education affected the decision of consanguineous marriage. However, the history of consanguineous marriage in the parents and the preference of consanguineous marriage, which affected the consanguinity. So consanguinity is still very common in our country. In the Kingdom of Saudi Arabia, according to the census of 2021, it is prohibited by 34 million, 2/3 Saudis, and the 1/3 expatriate. Saudi Arabia has one of the highest growth rate in the world, 400,000 live births per year, and large number of families, around 6 offspring per family. All of this led to that many primary recessive Mendelian diseases are very evident in the Saudi population, and this increased the possibility of characterization of new gene loci, as it happened with many studies where Saudi children contributed to those studies. And actually this study from Lامراض group showing that the steroid-resistant identification in children from consanguineous families is 38% compared to 13% from non-consanguineous family. Inherited renal disorders are mainly transmitted through, sorry about it, it's very sensitive, I have to be very careful, with autosomal recessive pattern. However, it's autosomal dominant and X-linked could happen, and the genotype-phenotype is very much correlated in autosomal recessive. However, it is not that much correlated in autosomal dominant, as Prof. Weber said, that because of the variable expression and variable penetrance. When we look at the genetic test available, we have the Sanger sequencing, which is used for simple tests such as Dennis Drage or cystinosis, where there is minimal locus heterogeneity. And then we have the copy number variation, where it is used for large gene defect with deletion or duplication, such as Kakut, as again Prof. Weber said. And then we have the panel-targeted genes, which is used in steroid-resistant nephrotic syndrome. And then we have the whole exome sequencing and the whole genome sequencing, which is used for overlap disease, and it is not very specific. This timetable summarizes the difference between different genetic tests. As you can see, with the targeted mutation analysis, the Sanger, it is highly sensitive with very little uncertainty or unexpected finding, which is completely different from exome or whole genome sequencing, where you'll find a lot of finding which might be difficult to interpret it and to explain. So what are the clinical benefits of genetic testing? It provides an accurate diagnosis of the underlying disease through minimal invasive and increasingly time and cost-effective tests. It might obviate the need for renal biopsy, such as in children with congenital nephrotic syndrome or steroid-resistant nephrotic syndrome. However, many of the pediatric nephrologists, they consider it as complementary in cases of steroid-resistant nephrotic syndrome. It can lead to reclassification of the original clinical or histological diagnosis, such as in Alport syndrome. such as in Alport syndrome, where calculation 4A35, where it could be misdiagnosed as having membranoproliferative glomerulonephritis, also in cases of congenital chloride diarrhea, which could be misdiagnosed as Bartter syndrome. Also, it can guide to prognostic and therapeutic decision in children with Alport syndrome. We can expect that post-transplantation, they will have antiglomerular basement membrane disease, and by doing the genetic, we can avoid using unnecessary immunosuppression in children with steroid-resistant nephrotic syndrome, and which is genetically mediated. Also, it can give clues toward an early detection of potential extrarenal features, such as in children with Kakut and PAX2, we have to screen them for eyes abnormalities. It can give us crucial genetic, it is very crucial for genetic counseling because it provides information about recurrence risk and also facilitates reproductive options. It offers pre-symptomatic testing opportunity for families members at the risk of having the same disorders. We test siblings for carriers or for early diagnosis. And it is also very important in setting of kidney transplantation, especially when living-related donation is involved. What are the barriers to use the genetic testing? I think many. The first one is genetic literacy. Many of us are unsure about when it comes to genetics. Also, the challenge of identifying the best diagnostic test for an individual patient considering the cost, the difficulties in interpreting the identified genetic variant, concerns about the cost and the reimbursement, the need for pre- and post-genetic counseling, and how to deal with variant of uncertain significance, which it could be observed in a large proportion of children. I would like to share with you the questionnaire, which many of you contributed. So we sent the questionnaire to the pediatric nephrologist through our group electronically, and 40 pediatric nephrologists, they answered the questionnaire, and we put in the questionnaire, is the genetic test is available to you? It is available to 62.5%, and it is not available for 37.2%. The next question, where are the tests is performed? In the majority, it was done outside the kingdom. Only in around 17% was done inside the kingdom. And then we asked which lab you use, and in the majority, it was a private international specific lab. It is genetic lab, and some of them, they used a private local non-specific lab, Al-Burj, and some they reported as others, and the others including the list on the other side, which is King Faisal Specialty, Noor Diagnostic and Discovery, and others. When we look at the labs available in our kingdom to do the genetic test inside the kingdom, we have King Faisal Specialty, Ru'ya Lab, Al-Burj Lab, and KAUST, King Abdullah University for Science and Technology. We have a lot of commercial labs where they send the genetic test to be done outside the kingdom. Also, we asked, are the services provided at your hospital free or not free? It is free only for 55% of those who answered, and 32.5% it wasn't free. And why the clinician requesting the genetic test? It was all of the above for the majority because of unclear phenotype or unclear histotype, or because the significant family history. What is the most common type of kidney disease for which the pediatric nephrologist requested the test? It was mainly for glomerular, assumed steroid-resistant nephrotic syndrome, followed by renal tubular disorders. And when we asked what is the commonest test you requested, it was whole exome sequencing in more than 70%, 3/4. And when we asked, is genetic counseling is available in your institution, the majority, more than 3/4, they said yes. And when we asked what is the barrier which impair you from requesting genetic test, it was mainly financial. This is merely financial. And then we look at the facilities of genetic testing and the papers produced from our kingdom. This is one of the earliest paper of the genetics done inside the kingdom, in the kingdom of Saudi Arabia. Dr. Al-Hamid, he looked at 49 families with steroid-resistant or congenital nephrotic syndrome, and he tested them, and he done the test inside the kingdom for 9 genes, and those panel gene. In those days, whole exome sequencing was not that much widely used. And he found, him and his group, they found that 51% of those children had the positive gene in one of those 5 genes, and mainly it was MPHS2 gene. When we look at our data from King Abdulaziz University, when we look at congenital nephrotic syndrome, 78.2% were positive, as you can see from the last column. And it was mainly MPHS1, followed by LAMP2. Steroid resistant was positive in 27.5%, 15 of those were NPHS2, and 4 were SMARCL4 for Shimmick, and 3 ADCK4. And as it would be expected for secondary steroid resistant, it was only positive in 1 child, and it was not significant because we don't expect them to be positive. Actually, from our cohort, those 2 cases were sent to Hilbrand, and using homozygosity mapping on those days, back in 2010, 2011, he found the ADCK4, and which is potentially it could be treated with coenzyme Q10. Another group of children, which widely seen in our kingdom, and we're more and more we're using the genetic test to diagnose them, is nephrocalcinosis and stone. In this group of children from 2 centers from our kingdom, as you can see, the majority of children had metabolic causes of the renal stone, either hyperoxaluria, cystinuria, hypercalciuria, urexuria, or familial hemoglobinemia hypercalciuria, or distal renal tubular acidosis. And when we look at those children, most of them, they were diagnosed around the age of 6 years. They had high percentage of consanguinity and family history. Those data were collected over between 2011 and 2021. In those days, we did not use the genetic that much, only in 1/4 of metabolic and 1/3 of the familial hemoglobinemia hypercalciuria nephrocalcinosis. This is changed in our kingdom, as now this paper, which was published between 2 centers, the inclusion criteria to diagnose cystinuria was to have genetic positive test. And this paper, which was recently published, it is multi-center from, I think, all of us, we are included in this paper. And again, the inclusion criteria to be included in this study as hyperoxaluria was that genetic test was done. Another group of patients who we used the genetic test as very important step in the diagnosis and the decision of treatment is atypical hemolytic leukemia syndrome, and I think the pioneer is King Fahd Medical City, Dr. Ainazi and Dr. Saeed Al-Zu'bali, and actually they published 2 papers, one in 2020, where the decision to continue clizumab was supported by the genetic positive test, and also another paper just published where the decision to stop the clizumab was supported by negative genetic test. I would just like quickly to share with you our data from King Abdulaziz University. Actually, our university, they work very much with, they are collaborating with Harvard. So we send a lot of, we have 2,140 children. The majority of those children, we send sample to Boston Children's Hospital. However, for commercial, because we want the result quickly, we send 104. Prof. Hildenrand, he does not give us the result if it is negative, because sometimes after a few years, it turns to be positive. So he sent only the positive results. So we have from him 178 positive results. When we look at the family history, it was available for 26%, so it was 24% positive, but if we look only for those available data, it is 92%, and for consanguinity, it was available for 90%, and when we look only for the positive, it will be 78%. What is the requested test? Similar to the rest of the kingdom, it was WES, and when we looked only at those we sent to a private lab, commercial, the positive test was 40%, and the negative test was 31%, and the R30 result was 29%. And of course, all of those are potential to discover new genes. When we looked at what type of disease we are sending genetic test for, it was mainly for glomerular disease, nephrotic syndrome followed by glomerular disease such as Alport and so forth. We tried to
2 minutes left.
Okay, to copy the Prof. Hildenrand study. So we looked at our data. As you can see, the commonest cause, again, Kakut in 39%, but we did not send much of those Kakut, so only 4% were the gene were identified, compared by the nephrotic syndrome, which is contributed to 20%. This is including steroid sensitive, and 14% were identified. I will just put examples where our data from the kingdom can contribute to the literature, because we have many uncertain genes which could turn to be new genes which could be reported. I will just go to the conclusion. So the conclusion, genetic tests provide causative diagnosis in considerable proportion of children with kidney diseases, at least 20%. This is more prominent in the kingdom because of the high rate of consanguinity. Genetics test is not available in around 1/3 of pediatric nephrologists practicing in the Kingdom of Saudi Arabia. Despite of the ability of labs inside the kingdom, the majority, more than 70% of the tests are done outside the kingdom. Genetics tests are widely recognized by pediatric nephrologists and used as a definitive way of diagnosis, with its potential for personalized treatment, such as children with steroid-resistant nephrotic syndrome caused by ACDK4, and also it can help very much in family screening. Thank you very much.
Thank you. Thank you very much, Prof. Jamila. It is the floor now for the questions. But I will just comment on the when you said it is not available for pediatric nephrologists, only 1/3. I think
available for 2/3, 1/3 not available. هم هذا الquestionnaire يعني.
Yeah, but I think for the government hospital it is available because it is done by outsourcing. I don't think there is any lab locally who's doing genetic study. All the labs, correct me if I am wrong, for King Faisal Specialist Hospital, even King Faisal, they send outside the country. But it is available, and through the MOH, they can do it.
Actually, I asked 3 geneticist colleagues, and I asked them, where is it done inside the kingdom? And they told me 4 labs, they are doing it inside this kingdom. And one of them said King Faisal, they send it outside, but I wasn't sure, but I put it just in case. But they said for King Abdul Aziz, Kaus, يعني, they do it inside.
Dr. Sousan, and microphone.
شكرا دكتورة جميلة. صراحة we really enjoyed this lecture. Some numbers were really shocking to me. The percentage of how many positive we got in correspondence to the consanguinity and the awareness of consanguineous marriages, that even though we're and in the 21st centuries, and we still have even higher consanguineous marriages. From your experience in looking at the literature, I mean, we do have cultural barriers. What would you suggest to break those barriers and help with the awareness and hence decrease the risk of these new mutation and new loci mutations that are happening? Thank you.
I am positive about it. As Professor Aran said, I am old pediatric nephrologist and I had practicing a lot across the years. I saw the attitude to genetic test, how it is changing across the years. Actually, when I came from the UK, when I tell the parents that I want to do genetic test, they used to be very angry and upset, and now they ask for it. And now when we discover a genetic test in a child, the parents, they ask us to look for carriers. And actually, it is what we do in our service. We refer them to geneticists, but we do the counseling ourselves. أنا صراحة أحس مسؤولية قدام الله سبحانه وتعالى. إني لازم أقول لهم it is you have to test all your children before they get married, so that the bride or the groom is not. And actually, they already, most of them, they know about that. I think the consanguinity is this tradition. I don't think we can change it. That's easily. If you look at the other part of it, because يعني مثلا الأم أو الأب، معلش أتكلم الحتة دي بالعربي، يعني لما يزوجوا لواحد وتتربى قدامه، يعني هو يكون مطمن على بنته وولده أكثر. فأنت تشوفي لها من الناحية الثانية يعني برضو. It is tradition and it is a culture. Maybe, but people, they should be aware of the genetic disease they have. يعني I think this is. طبعا إحنا we are more awareness. It is happening. It is a fact. يعني.
Dr. Mohammed.
Thank you. One comment, which is a great job, يا دكتورة جميلة. Always, يا Prof. يعني we get learning from you a lot of lessons صراحة. Thanks for your great job. The second thing, إحنا this is it's not bother us to mention it. And we need a time to have our national efforts, because it seems that everyone have the efforts, and these efforts really it's very scattered in a very big, huge national problem. And there is already a national initiatives for gene and inherited diseases control. And I think the pattern here inside the country is that first come, first serve. If we do have a clear strategies of controlling inherited diseases, early discovery, early reportings and tracking, we can present it to the ministries, and we can get a lot of it, and it will be implemented. And haram these scattered dissolve here and there.
Sure.
Yeah. So
actually, I feel jealous from Prof. Bokenhauer. He was saying, بكل confidence, the incidents from out of our clinic, قال القتل. فقالها فإحنا we need actually yes we need يعني it is a time يعني ما شاء الله تبارك الله تطورنا كفاية. I think it is time to do registry.
And the second thing, but just a highlight, till what we will continue with the scattered family screening efforts. Now we're not talking about the index cases. I think it's still people doing a fair job for the index cases, but till now there is no system to catch up a lot of members, either carrier or even affected cases in the family screening. Why family screening is not systemized in a way that ensure an obligate discovery and testing and involving in the assessment?
Actually, testing healthy, normal people, there is a lot of ethical issues around it. يعني إنك you test them genetically. يعني قصدك إنك تسوي genetic test for
family screening of index cases. Yeah. Not a generalized community screening.
Yeah, we do that. We do that. In our center, I think most of us we do that. يعني حتى ذاك اليوم كنا بنتكلم في hyperoxaluria meeting كان بيقولوا إنه they were diagnosed the case and the parents they want the hospital to screen for 15 children. يعني ما شاء الله تبارك الله راجل متزوج أكثر من واحدة وعنده 15 children. فهم في there is awareness and there is it is offered for us. We do offer it. يعني ونسويها كيف نسوي whole exome sequencing لما we want to diagnose and نسوي سنجر اللي هو ب 600 ريال لما نبغى نسوي بس الكارير.
Okay, thank you very much, Prof. Jamila. We will move to the fourth speaker if he is ready.
No?
So we will
Can you hear
move
me?
to the fourth speaker in this afternoon session. Our fourth speaker is Professor Christoph Licht. He is a professor in pediatric and a consultant pediatric nephrologist at Sick Children Hospital in Toronto, Canada. Professor Licht is an international expert for complement-mediated kidney diseases and chronic protein-uric kidney diseases. His work has advanced the understanding of the pathogenesis and management of atypical hemolytic uremic syndrome and C3 glomerulopathy. Professor Licht, the floor is yours.
Thank you very much for this very kind introduction. Thank you very much for the invitation to this beautiful conference. It's a pleasure and it's an honor to being with you and to presenting and to learning together with you. I would have much preferred to be in person at your place, but I hope for this opportunity in the near future. I hope that I can share my slides. Could I just get the permission to share my screen? At the moment, I cannot share my screen. I think the IT people in the background hopefully can do that.
It is supposed to be showed from our side.
I made some final adjustments and I was hoping I could share my screen from here. Is that possible? Can you please let me know? Hello?
In fact, the previous speaker, the slide was showed from our side, but since you requested to be shared by yourself, it may take some few seconds.
Okay, I'll wait.
Yeah.
Thank you so much.
Can you try now?
Still disabled. That is the screen, but again, I would like to share from my side, if that's possible, with the final adjustments.
Can you move to the next slide, Professor Licht? It is showing
Again?
up now, the first one.
Yeah, it's the first one, I know, but I would need to be able to share my own screen with you, if that is possible. And that seems to be still disabled.
Yeah. It is showed up now.
Yeah, that is the, well, okay, I'll just work with the slides that you have, and I will try to add from memory what I wanted to adjust. Okay, so the title I was given to present on is an update on atypical HUS. You have seen on the previous slide my disclosures. Maybe you can just briefly go back, just one slide back, please. That's my disclosures. Next slide, please. This is the overview of what I'm trying to, just one back, please.
Okay.
What I'm trying to present. I will give you an overview over the TMA as a disease spectrum, We'll talk briefly about the central role for complement in TMA pathogenesis. We'll focus for a moment on infections and their critical role in the manifestation of TMA. I will follow with a few practical aspects in terms of diagnosis and treatment, especially in particular treatment duration, and end up with a few perspectives moving forward. Next slide, please. And next slide. In the first place, TMA, as you all know, and we're all pediatric nephrologists, or we're nephrologists, we're dealing with a clinical presentation, and this clinical picture is characterized by thrombocytopenia and microangiopathic hemolysis with the appearance of cystocytes, high LDH levels, low haptoglobin levels, and decreased red blood cell counts. This signature that we find on lab is accompanied by a varying picture of disease manifestation, both in the kidneys but also in extrarenal organs, as you can see here. Next slide, please. A pathologist. Next slide, please. Next slide, please.
Can you see the slide now?
Yeah, I see this one, but this is 2 down. I need to go at least 1 up, and there is an animation there.
So we move next, yeah?
No, backwards, please. And yeah. 1 back, please. Okay. So this is what we are clinically facing, and a pathologist, next slide. Next slide, please. Would see a histological lesion that is characterized by pathology in small blood vessels, arterioles, and capillaries, and that pathology is characterized by the thickening and inflammation of the vascular wall, the detachment of endothelial cells, the widening of subendothelial spaces, and the occluding platelet thrombi. Next slide, please. And it's important to understand, just click again. Click again, please. I don't know how I can help it from here. As I said, I would like to operate this myself, but yeah, okay. Let's try, but if it's not working, then maybe we should make another effort to hand it over to me. So the pathologist will see this lesion that you have just seen, though hidden behind this text box, that is pretty indistinguishable between the various causes for TMA. And what we're really working on a lot at the moment and advancing our understanding is the causes behind this lesion. One form is pretty well known, which is the primary form of aTPL-HS, which is the dysregulation of the alternative pathway that you see here in a cartoon on an endothelial surface, where the dysregulation of the pathway leads to an overshooting deposition of the MAC complex that injures the endothelial cells and results in the activation of the clotting cascade and thrombus formation. Can you please move on? And click again, or just leave it. In 60%, about roughly, of these patients, we find a genetic cause for this condition. You see here listed the known either complement activators, C3 and factor B, or complement regulators, most importantly factor H, and you know the others as well, or factor H autoantibodies that are participating or they're contributing to the dysregulation of complement control. Altogether, be it gain of function or loss of function of these mutations, or the presence of these antibodies leads to overshooting complement activation and the injury to the endothelium. Next slide, please. Next. Next. Thank you. The question is, besides these primary forms where we know that the complement system and those genetic and autoimmune forms play a key role, what is it about these other forms where we have an indistinguishable histological lesion, but we don't have a clear understanding of the mechanism? And what we start to understand is that in some of these secondary forms, a complement plays also a role, and that can be due to rare underlying genetic conditions. It's rarer than in the primaries, but it's not impossible. But more importantly, via a transient recruitment of the complement system to contribute to the mechanism of the disease. Next slide, please. And there is an important paper from the French group in Paris that basically reviewed their own experience with their secondary forms of atypical HUS, or HS, I should say, in France, and reported that different from the atypical form, where they found complement mutations in up to 80%, in 80 patients out of 125, which is 60% of their patients. So that's what I just told you. Virtually a very small group, 5% only in the secondaries had complement mutations. And that is reflected by the fact that these patients did not have a significant response to eculizumab treatment, so the specific complement blocking treatment. Please, the next slide. Next slide. Next. However, we are at the moment still left with this concept, and this is very important to me, that we have basically a role for complement in two forms in these TMAs. One is this primary form. We started talking about that. 60% of patients with a definable defect leading to complement dysregulation and injury to the endothelium, with the consequence of the activation of the clotting cascade and the clot formation. But in the secondary forms here in the purple box, while there is very small numbers or no patient with genetic forms or antibodies, complement might be transiently involved. And that is an important take-home message, since that leads to the potential for anti-complement treatment in these patients in a timely, limited fashion as well. Next slide, please. And the next one. So now the question is, with this background, so we have the primary atypical HUS and we have the secondary forms, how can we make sense of the role of complement and the manifestation of the disease? And what is maybe the most helpful concept that harmonizes those two aspects is a clinical observation which we all have made and share, which is that most of these patients present with a preceding inflammatory insult. So most patients have an infection and then manifest their TMA. And the concept that we propose is that where basically these patients follow a multiple hit two or more multiple hit hypothesis of manifestation of their disease phenotype, where you either have an absent or you have a mild or a severe form of an underlying risk factor. And that could be, for example, a mutation or the presence of antibodies. And then you have environmental triggers that combine with these pre-existing risk factors to basically, in a dual hit fashion or multiple hit fashion, enhance the pathology to the endothelium, and with that, make this patient cross the line of disease manifestation. Next slide, please. And this is reflected in two ways, both if you take registries and look at the reported numbers or incidence of infections. Here, this is a relatively old paper already. We reported on 71 patients in a European cohort, in whom 27, so it's somewhere between a quarter and a third of these patients, not quite half of them, did report infections. The specifications are seen here. Both viral and bacterial infections are reported. Next slide. But also, as I said earlier, there is the rare report of the presence of underlying mutations, even in TMA patients with an identified specific infectious condition, as you can see here on the left side of this slide, in the left column. And I lead this column by STEC-HUS, which would be a talk in its own right. But even there, underlying mutations are reported to possibly contribute to the disease manifestation or the severity of the phenotype. Now, you may say, and I'm with you, these patients could be considered primary atypical HUS patients with the specific mutation infections, be it an E. coli infection or be it an influenza infection or a CMV infection, just being the trigger that kind of unravels the primary atypical HUS. And I think this is a very nice conversation to have, but at the moment, we're still working towards a more precise terminology to express that. But I just wanted to make you aware of both the incidence of those infections and also the prevalence of potential underlying mutations in such patients. Next slide, please. And this is very important to connect the two dots. The infection and the manifestation of the disease becomes very important and becomes very tangible if you focus for 1 second on a specific or particular infectious disease that comes with a severe TMA phenotype, which is pneumococcal HUS. You see here two endothelial cells, and on the left side, you see basically the normal scenario, how endothelial cells protect themselves against complement activation, which occurs at all times, like the clotting system that is always active. Complement is also always active. And the surface of an endothelium is protected through the binding of factor H to specific structures like these glycocalyx sialic acids to protect these cells against the attack by complement. If you now, for whatever reason, lack the binding sites for factor H, and that could be a pneumococcal infection, could be other causes, could be medications, could be mechanical stress and hypertension. If you lack these binding sites, factor H cannot bind. You have a relative deficit of factor H, and with that, a lack of defense, and complement can take over, become overactive, and injure the cells. And in pneumococcal HUS, we know this a bit more in detail, and there's very nice literature that has come out recently that shows how an enzyme that's released by pneumococci, it's called neuraminidase, is cleaving basically those sialic acid residues. So with that, factor H doesn't find the proper binding sites and leaves the endothelium unprotected. And I want you to take that as another learning point home, since this is a principle that we have in the lab tested or demonstrated to being applicable also, for example, to CNI toxicity. So cyclosporine or tacrolimus does the same thing. It also cleaves those sialic acid residues and creates a relative deficit of factor H on endothelial cells. And with that promotes complement activation, and with that might contribute to TMA following CNI treatment. Next slide, please. How does this all translate now into the practical management of our patient? Next slide. So, as I said earlier, it is a clinical diagnosis in the first place, and it remains a clinical diagnosis. We have this, the patients presenting with the MAHA and various pictures of organ involvement. And then it is our the clinician's job to exclude the well-defined Shiga toxin and HAS and TTP cases, which then leaves us with the secondary forms of atypical HAS. You see this large column here on the right side. All these forms of secondaries where we have just learned complement might play a temporary role. And if we have excluded all of them, we land on them on the diagnosis which are suspicious for primary forms of atypical HAS, in whom we then can find mutations in antibodies. Just click the animations through, please. Next. Next. And next. And with that, a very beautiful paper published by Fadi Fakouri and Veronique Fermo-Bacci just last year, I would really recommend you to take a look at this paper. Beautifully summarizes the state-of-the-art workup for these patients, which includes, as you see here listed on the table, the biochemical signature to find evidence for complement involvement, and the genetics. So that's the top and the bottom of the table, and then in the middle there is some functional testing which I'm going to refer to in a second. Just click through, please. Next, next, next. We just published, and it's kind of a hard read, but maybe it's still an interesting paper to take a look at. An evaluation of basically it's almost a Cochrane review type approach to look at all reported cases of atypical HAS, and the question was, can we distill a signature of complement activation or involvement in patients with atypical HAS? And yes, in fact, we find in these patients low levels for C3, CH50, AH50, and factor B, as you can see on the right side. And we see activation products in form of C5a, C5b9, factor BB, and factor BB enhanced. So that would be the signature. And in an ideal world, we would have access to these assays to help us to diagnose and identify patients with atypical HAS driven by complement. Next slide, please. Next. Okay. I promised that I will talk about these functional assays. So many clinicians do not have ready access to these larger panels of complement biochemistry. And even if we had, there is still people who claim that we need smarter assays to diagnose complement involvement in TMA. And this is actually beautifully spearheaded, if you want, by the group of Giuseppe Rimuzzi. Marina Norris is the lead person in this effort, in a group that has basically mimicked in the lab the situation of the endothelium in a patient with TMA or atypical HUS. So they take endothelial cells, expose this endothelium to the serum of the patient, and then measure C3 or C5b9 on those endothelial cells. And what you see, or what they see, and this is represented here both in IF images on the left side and the bar graphs that just quantify these results on the right side, is that in patients with complement involvement, TMA patients, HAS patients with complement involvement, you find enhanced C3 and C5b9 deposition on these endothelial cells. And you can stimulate this signal, enhance the signal by pre-activating the endothelial cells with ADP. So there's a functional assay that gives us probably at the moment the best insight into complement involvement in such patients. Keep clicking, please.
Professor Licht, we have 4 minutes left.
Thank you. So while this is helpful to basically guide us in terms of deciding whether complement is involved or not, another big debate in the field is complement. For how long do we, in a meaningful way, treat patients with anti-complement treatment, and how do we monitor for safe complement targeted treatment discontinuation? And I want to show you basically 3 references for that. One is this slide summarizing the insights from the global atypical HUS registry. The message here is basically patients are at risk for recurrence of atypical HUS after treatment discontinuation if there was extrarenal manifestation prior to eculizumab treatment, if there were genetic mutations found, and if those individuals had a family history of atypical HUS. Next slide, please. The most recent and the strongest paper in the field is probably published again by Fadi Fakouri, who in a prospective national multicenter open label trial in both children and adults studied 55 individuals and found that the ones who recurred after treatment discontinuation in 51% had complement mutations involving MCP, factor H, and factor I mutations. The frequency was 23%, 13 of 55, 23%, and 6 of those were children. And the risk factors, besides the presence of those genetic variants, were female gender and increased C5b9 levels. The good news is that restarting eculizumab helped to control the disease in most patients, but not in all. So there was 1 patient who progressed to end-stage kidney disease. Next slide, please. And next. I'll skip those since they are just illustrating what I just told you. Next. And next. Way more aggressive than what probably all of us do is the Dutch approach, where patients are basically in the Curious study, it's a national effort, discontinued from eculizumab treatment after 3 months. There's details to the approach, which I skip, but the message is basically without exception, patients are on eculizumab when needed, but they're discontinued after 3 months. Next slide. And the paper that reports the outcome of this effort, next slide, please, is just coming out. And I think this is really interesting to take a look at. In 81% of these patients, complement mutations were found. All patients, 21, who were treated with eculizumab had full recovery of the TMA parameters. Renal recovery was found in 18 of those 21 patients. All of these 18 were withdrawn. 4 of the withdrawn ones relapsed. In those relapsed patients, eculizumab was reinstituted within 24 hours, and they report that at the last follow-up, no chronic sequelae were found. Next slide. Next slide. Yeah. And with that, they basically propose that this discontinuation is fairly safe and is also associated with a significant cost reduction in the use of this very expensive treatment. There is controversy, as you can appreciate, and maybe we have a quick discussion about that in the Q&A session. I have two more slides, and then I will finish. Continue, please. So where do we go from here? Next. There's two observations that I want to share with you without going into the details. The field of complement-mediated diseases is exploding, and it includes, besides atypical HUS diagnosis like C3G, ANCA vasculitis, IgA nephropathy, membranous nephropathy, to just mention the highlights for the nephrologist. And on the far right column, you see that in all of these diagnoses, there's various degrees or various levels of clinical trials for specific anti-complement drugs, either on the go or expected. So this is a highly active, very field with very promising activities, and as far as published, many promising results. Not all were successful, but many promising results. Next slide, and that's the last one. And this reflects that we have again, a very dynamically growing field in terms of drug development, where you see, this is obviously the complement cascade, an increasing number of drugs at the bottom of the slide that address the terminal pathway, but we have also these top part of the slide, these new drugs coming up that are addressing the proximal portion of the complement cascade, which hold high promise to be successful in diseases like C3G, but also IgA nephropathy and maybe membranous. So this is actually fantastic times to be in with respect to complement-mediated diseases. Next and final slide. And with that, I thank you for your attention and would be happy to address questions if I still have a moment for that. Thank you very much.
Thank you. Thank you very much, Professor Lecht, for this very informative presentation. The time or the floor for questions now. We will allow 2 questions because we are already past our time by almost 1 hour.
Hi, Chris. This is Maghrabi, your fellow. I hope that you are well. Thank you for your nice lecture. One quick question. Is the secondary infections in proven negative genetic case can raise the threshold, and the risk of recurrence after passing the acute is more? This is my first question. And the second question, what's your protocol in proven genetic cases that end by dialysis for post-transplant? Thank you.
I hope that I caught the second question. So the first question, the role for the manifestation of disease via the infectious trigger seems to be the same both for first and subsequent manifestations. So there is a role for infections also in the state of recurrence. If I correctly understand your question, the second question, then you were asking about the use of eculizumab or anti-complement treatment, complement modulating treatment. I would actually really prefer to say in the various scenarios. So in patients, let's start with the ones that are probably most difficult. It's the dialysis patients, so end-stage kidney disease, and the question for how long do you treat before you give up. it's probably very similar to what we practice with patients with severe AKI for other reasons. I would personally not give up, and this is reported, and for many discussions, my colleagues would agree, I guess, that 6 months is kind of our threshold, after which we really lose hope. But up to 6 months, I think we do have hope that there is some late recovery. In terms of timing of treatment, we are still transitioning to this more kind of current management concept of, even in a genetic form, treatment should be temporary, so between 6 and 12 months, and then you should discontinue regardless of the mutation. Maybe with the exception of very aggressive factor H mutations or a family history or personal history where you had very bad disease outcomes or manifestations that you don't want to see repeating themselves. But other than that, without those, besides these exceptions, 6 to 12 months, and then discontinue and monitor and reactivate treatment if need be. In transplant scenarios, you should, that's our concept, protect the patient from the get-go and do not wait for recurrence. There's other concepts discussed, but we would not allow for recurrence and then treat only when you have a problem, if you want. And then the same time windows would apply, 6 months, 6 to 12 months. And that is informed by the fact that most of the recurrences, especially with antibodies, but also with mutations, occur during these first 6 to 12 months. And after that, the risk significantly decreases.
Thank you, Prof. Lacht. I have just a question now after the introduction of riflizumab, and still we have also ocrelizumab. From clinical point of view and the strategy of managing patients with HS, do you think there is can we say we can just use riflizumab as we used to use before the ocrelizumab? Or do you think maybe in the initial management, we should use ocrelizumab as short-acting and maintenance can be riflizumab? This is my question.
So you're talking ravulizumab versus eculizumab and in the acute and chronic phase of treatment?
Yes.
Yeah. So it's a very good point that you're making. I know that the company, and thank you for this question, the company is advertising to basically use ravulizumab like eculizumab. Especially as pediatricians, where we are less eager to, and maybe less confident to jump right away on a long-acting drug. Our strategy in these patients, actually we don't have access to ravulizumab in Canada, we have access to eculizumab, so it's a theoretical answer that I'm giving you. But my approach, and that's what I have shared with others in the past, would be to use eculizumab for the early phase of establishing the diagnosis, regain control over the clinical presentation of the patient, and then transition to ravulizumab and basically space out treatment intervals. I think this is that's what I would feel most comfortable with, since both the under and the over treatment seems to be better controllable with a shorter acting drug. But I'm open to, and I'm aware that there is other opinions on that, and I don't want to monopolize that answer. But that would be my take on that question.
Okay, the last two questions.
Thank you for this excellent talk. My question is, if the kidney already affected and the liver, if we can do dual transplant, liver and kidney, do we need to continue on eculizumab for life, or we can just follow the patient and we can, after that, we can stop the medication?
Excellent question again. It's a little, so what you're referring to is a double liver kidney transplant, and I assume that you are thinking about factor H mutations in the first place, since obviously you would not, apply this to a patient with a non-soluble factor, a non-liver-borne factor defect, if you want. So let me assume that you're the most prominent example of those liver-borne factors would be factor H. So let's focus on that scenario. So the outcomes of patients with successful liver kidney transplants seem to be very good. The stakes are relatively high, and there was a steep learning curve in the literature that basically reflects the learning of managing these patients perioperatively, preventing early recurrences in a time where people had limited or no access to eculizumab and had to basically learn how to navigate this early high-risk phase for recurrence. But the mid and long-term outcomes are really convincing, and the countries with kind of limited or no access to this expensive drug still report and continue to being interested in eculizumab, in this concept of the dual or combined liver kidney transplant. Now, your question was an excellent one, and so let me put it into these words. I think personally, if you have access to eculizumab, I would always prefer the medical treatment over the double or combined transplant approach. If you had only very limited access to eculizumab, let's say for a very short period of time, but you had access to a combined liver kidney transplant approach, then what I would consider the most reasonable approach would be to use eculizumab perioperatively for the early phase with the highest risk of recurrence, to protect basically or to ensure a successful combined liver kidney transplant, and then discontinue as you demonstrate that factor H levels have normalized, and with that you're basically you have restored and supply, and you have healed the defect. So I think at that point you can safely discontinue eculizumab, but I would use it during the early vulnerable, high risk for recurrence perioperative phase.
Thank you very much, Professor Licht, for the talk and for answering the question, and hope to see you soon again. And with this, we come to the conclusion of this afternoon session. Thank you for the scientific committee and for the organizing committee. Thank you very much.